and really sorry for the inconvenience. There is some issue. I think I fixed it. Let us check this time. Because the reason is because it's getting recorded, because many students are not watching it right now. So anyway, I have to repeat it, point number one. Second is, if I'm seeing, because I'm seeing myself and taking, if there is a substantial lag here that keeps on distracting me, like I'll be telling something here, but what I'll be seeing in the screen is something completely different. So it's coming like 15-20 seconds before what I have said. So that's kind of distracting so much. So that's why I wanted to settle this off and come back. So sorry for that. I think now, are you able to see? I mean, are you feeling any lag from your side? No, right? No, everything is fine in your side. Cool. So sorry for that. So just I'll repeat in just 5 minutes. I'll try to finish. So we're talking about spinal cord disorders. I've started a new page now. So just let me finish off the structure of the spinal cord in 2 minutes. So where I'm drawing the posterior and the anterior. Stuck. Is it stuck? Is it stuck? Okay, now. I mean, no, we got a big thunderstorm right now. So that is the reason. Yeah. That's because of thunder. It was a huge thunder. That's why. Anyways, fine. So let us go back to our this thing. So posterior and anterior. So we know it's a head-shaped structure that we're going to encounter here. Yes. So this is going to be structure, head-shaped structure. So whatever I've drawn in orange here will be basically the gray matter to some extent. And the remaining everything is going to be predominantly the white matter. So that's how it's going to be. So this is the posterior and this is going to be the anterior. And one of the important structure that is located in the anterior side is the anterior cell. And apart from that, this area, we know what is it. So this is going to be the posterior column. This is going to be the dorsal column, or this is going to be the posterior column. And at the same time, we have two more tracks on the lateral side. Let me draw in this side for a change. So you're going to have something called a lateral spinothalamic tract, and you have the lateral corticospinal tract. And as I told you before, let us recap one more time. So the dorsal column will be arranged in a different way. So you have medial, you have lateral here. So from medial to lateral, they'll be arranged in the form of S, L, T, and C. So sacral, lumbar, thoracic, and cervical. So this is how the lateral dorsal column will be arranged from medial to lateral. And as far as the lateral spinothalamic tract is concerned, from medial to lateral, it will be arranged in the form of C, T, L, and S. It will be the reverse. We know why, because it's going to cross from the other side. So which means spinothalamic tract fibers that are ascending up, they're basically coming from the other side and moving up. So that is the reason why we are getting this kind of issues. Whereas the dorsal column, on the other hand, is ascending straight up like that. So it's not a problem. On the other hand, your lateral corticospinal tract is basically a descending tract because it's a motor pathway. So they are basically coming down like this. And from here, they will enter the anterior horn cell. So from the anterior horn cell, they're going to give rise to the motor pathway. So fine. So we don't want to discuss about that. So it's going to be the ipsilateral only on the same side only. And as far as the corticospinal tract is concerned, if you see how they are going to be arranged from medial to lateral, the most lateral will be the leg, medial will be the arm, and in between it will be the trunk. So these are the arrangements of dorsal column, lateral spinothalamic tract, and the lateral corticospinal tract, which you have discussed just some time back. Just I'm recapping one more time for the purpose of recording. So once we have known the anatomy, we need to know the patterns. That's what I told you. So as far as the spinal cord disorder patterns are concerned, we have some important patterns. So the first one is going to be the Brown-Sequard syndrome. Then after knowing the patterns, we need to know about the tracts that are affected. And then we have the clinical outcomes of those involvement of tracts. As far as the Brown-Sequard pattern is concerned, it's nothing but any section of spinal cord. Any disorder can cause this. Usually a tumor will cause this kind of Brown-Sequard kind of a pattern. So I can write that one particular side of the cord will be completely damaged, which means what are the tracts that are affecting the spinothalamic tract on that particular side, posterior column on that particular side, corticospinal tract are also affected on that particular side. This spinothalamic tract involvement on one side will result in contralateral loss of pain and temperature. And of course, involvement of posterior column will result in ipsilateral loss of posterior column sensations like fine touch, pressure, vibration, joint position, conscious proprioception, and you have the cortical sensation. All these things will be lost on that particular side. Corticospinal tract closely follows the dorsal column only, so they also will have ipsilateral loss of power. So I can write at ipsilateral Yeoman palsy, Yeoman paralysis below the level of the lesion. It will be paralyzed because it's a descending pathway. So fine. So now apart from that, as I told you, if it's affecting the cervical cord or the thoracic cord, your intermediolateral nucleus also will be affected. Because of intermediolateral nucleus involvement, you might develop Horner syndrome ipsilaterally. And at the same time, you can have additionally element type of paralysis at the site of the lesion. There will be element paralysis on the ipsilateral side only at the site of lesion. That is because of the damage to the anterior horn cells and the nerve roots at that particular site. But apart from that, there will be Yeoman kind of paralysis only below the level of lesion. All right. So then we also have discussed, so this is the basic Brown-Sequard pattern, hemisection of the spinal cord. Then we have the anterior spinal pattern where your anterior 2/3 of the spinal cord will be damaged. So let me draw like this. So anterior 2/3 of the spinal cord will be damaged. So this is the spinal canal. So this is the site of damage. So here the posterior 1/3 will be spared, which means we already talked about something called dissociative sensory loss. I'm going to reiterate again. So anterior 2/3 of the spinal cord is lost means you'll be losing the lateral corticospinal tract. You also will be losing the lateral spinothalamic tract, and you'll also be losing the anterior horn cells and everything in that particular zone. But what will be spared? The posterior 1/3 will be spared here, but anterior 2/3 will be affected. So typical example is anterior spinal artery occlusion, which you have discussed already. As far as the lateral corticospinal tract involvement is concerned, there's going to be a ipsilateral. I mean, it's not ipsilateral. Again, it will be a bilateral because the entire cord is affected here. So it's going to be a bilateral Yeoman paralysis below the level of the lesion. And there can be element paralysis at the site of the lesion, but there's going to be a bilateral Yeoman paralysis below the level of the lesion. And because of the corticospinal tract involvement on both the sides here, there will be bilateral loss of pain and temperature below the site of injury. And because posterior 1/3 is spared, you will have no loss of fine touch, pressure, joint position, and all these things. So there will be no loss of posterior column sensations. As we discussed already, this kind of sensory loss is an example of a dissociative sensory loss. And we already discussed about this. If the difference between the thalamic stroke and this kind of bilateral sensory loss, which means thalamic strokes will not be dissociated. Thalamic strokes, there will be no dissociation. Even cortical strokes can be dissociated, but thalamic strokes, very clearly, there will be no dissociation. Whenever you have bilateral sensory loss like this, if you want to differentiate from thalamic strokes, this will be the key point. The thalamic strokes will not have any dissociation in the sensation, which means all the sensations will be equally affected in a thalamic stroke. So of course, this is going to be anterior spinal syndrome. The best classic example is anterior spinal artery occlusion, which we have discussed already. Then we have a posterior cord syndrome. So where the posterior 1/3 of the spinal cord will be affected, plus or minus the corticospinal tract. So in this condition, this is the area of involvement. Bilaterally, the posterior cord will be affected, which means the posterior 1/3 is the one that is predominantly affected here. That is going to involve the posterior columns. But what is spared? The anterior 2/3 is basically spared here. But depending on the type of the disease that is affecting this, so usually the lateral spinothalamic tract is the one that is definitely spared, plus or minus spinothalamic tract can also be spared. So in this setting, definitely there will be loss of posterior column sensations below the level of the lesion. But remember, this will happen bilaterally. As far as the anterior 2/3 is concerned, there will be no loss of pain and temperature. Depending on the disease that it is producing this kind of posterior cord disorders, your corticospinal tract, may be affected or they may be spared. It depends on what is the disease that it is causing. So as I told you, the best example will be the tabes dorsalis, which is nothing but the syphilis of the spinal cord. Most of the time, tabes dorsalis patients will definitely be having extensive involvement of the central nervous system, but this is an obsolete disease. Nowadays, we don't see any tabes dorsalis. It's a late complication of syphilis. It's tertiary syphilis. What are the phases of dorsal root ganglion involvement? Yes, they can have severe pain, which we'll be discussing after some time. I'll tell you when I tell about extramedullary versus intramedullary, that time I will tell there will be some severe root pain in that setting. That is because of dorsal root ganglion involvement only. And there is no point in discussing about tabes dorsalis because it's a completely outdated disease. In tabes dorsalis, the prominent feature will be the posterior column involvement. And apart from that, we have two diseases that are very common in the modern setting. That is one is SAC, that is subacute combined degeneration of the spinal cord. And we also have the Friedreich ataxia. Remember, both are basically demyelinating disorders, which we have discussed already. Demyelinating disorders. So demyelination usually involves the tracts that are heavily myelinated. There are two tracts that are heavily myelinated. Of course, the most heavily myelinated tract is the posterior column. So any demyelinating disorder of the spinal cord will definitely affect the posterior column. And second tract that is also to a great extent heavily myelinated is lateral corticospinal tract. Both are heavily myelinated because they are evolutionarily very, very modern tracts. So that is the reason both these conditions will have posterior column sensory loss. And the level will be variable depending on which area it is affected. At the same time, both the patients will be having this human type of weakness also. Bilaterally, both will happen bilaterally. There won't be any specific side preponderance unless and until it is there because these are generalized disorders. Because they have human weakness, their TTRs might be active. They might show Babinski positivity. All these things may be there. That's fine. So we'll be discussing about how to differentiate between a human element, muscular and neuromuscular junction disorder in some time. Before that, you know these two things. DTR exaggeration and Babinski positivity is very important features of both these disorders. And before going into the next type of presentation, it's also important to discuss about something called a Friedreich ataxia. It's a very common question in exam. So usually when you will diagnose Friedreich ataxia in exam, whenever the patient is absolutely young, usually will be less than 15 years in exam, and they'll be coming with some kind of balance kind of issues because posterior column will be the first thing that will be affected in Friedreich ataxia. And you know it's a genetic disorder, autosomal recessive disease, and the disease related mutation is present chromosome number 9, and the gene that is associated with Friedreich ataxia is frataxin gene. And you also know it's a trinucleotide repeat disorder. And a triangular repeat disorder means they are going to result in something called a GAA repeats. So this is what is going to happen in Friedreich ataxia. We know that. So it's a trinucleotide repeat disorder. And you also would have studied in pathology what are the features of trinucleotide repeat disorders, like genetic anticipation and the number of repeats directly proportional to the severity of the disease. So all these things you would have studied already in the pathology section. But right now you have to know that this is a trinucleotide repeat disorder. And as far as the clinical features are concerned, usually it's a young child who presents with balance issues. Typically, whenever they close their eyes, they feel that balance issues because that's an indirect evidence of Romberg phenomenon or Romberg sign. And when you examine these patients will have Babinski positivity, and they'll be having Romberg positivity. That's because of posterior column involvement. So this, because of corticospinal tract involvement. This, because of posterior column involvement, and they'll have severe balance issues. And at the same time, almost all the posterior column sensations will be lost. They will not have the joint position. They will not have that conscious proprioception. And many times skeletal issues will be there in these guys, in these children. Like for example, they will have pes cavus. Very commonly, they can have scoliosis. They can have hammer toes. But pes cavus is a very usual exam point to understand. They give this very commonly. And most of them tend to have diabetes mellitus, which will be early onset by around 15-16 years of age itself. And they'll have cardiac issues. Very commonly, they're going to have cardiomyopathy, especially in the form of either hypertrophic cardiomyopathy or they can have a dilated cardiomyopathy. But even though hypertrophic is the one that is commonly asked in exams. Plus, at the same time, they will have a subvalvular aortic stenosis. That's a muscular type of septal hypertrophy. So they'll have a subvalvular type of aortic stenosis also. So this is quite classical. A young child coming with balance issues with recurrent falls, examination showing Babinski positivity, Romberg positivity, skeletal issues, diabetes, cardiac issues. So this is going to be the classic presentation features of a Friedreich ataxia. And more importantly, these patients may have associated peripheral neuropathy. Peripheral neuropathy, this is a very peculiar thing. So Friedreich ataxia, the pathophysiology is completely different. It can be linked to vitamin E kind of a deficiency kind of sort of a thing. So they'll be having peripheral neuropathy also. This peripheral neuropathy is the reason why they can have suppressed DTRs in certain places. Certain places may have low DTRs. For example, especially the knee and the ankle are the one that are predominantly affected. To know why knee and ankle are affected predominantly in the case of peripheral neuropathy, you need to wait till I discuss on the peripheral neuropathy. So the knee and the ankle jerks will be affected. So this is a kind of a paradox. What you're seeing here is the ankle jerk and the knee jerk is most of the times not seen, but the patient is exhibiting a Babinski positive phenomenon. This is quite contradictory. Usually in a corticospinal lesion, you expect a DTR to be exaggerated. But here the DTRs are suppressed, but the Babinski is positive. This phenomenon is what we refer to as an absent ankle with the extensor plantar response. Whenever they ask about absent ankle with extensor plantar, the first two diagnoses you should answer in exam is one is Friedreich ataxia and second is subacute combined degeneration of the spinal cord. Because even in subacute combined degeneration, you know, even though the etiology and pathophysiology may be different, in SSCD the problem is B12 deficiency. B12 deficiency does two things. One is demyelination at the spinal cord level. So this demyelination at the spinal cord level because of B12 deficiency will result in corticospinal tract involvement and posterior column involvement. So you're going to get Babinski positivity because of corticospinal tract involvement, and you're going to get loss of posterior column sensations because of posterior column involvement. At the same time, they produce peripheral neuropathy also. B12 deficiency is a very important cause of peripheral neuropathy, and usually it will be of axonal type. Axonal type means it will be length dependent. Length dependent means you will be affecting more of a distal areas more than the proximal areas. So once again, you can have an absent ankle jerk or a knee jerk. So whenever they ask you about absent ankle jerk with a positive Babinski or a plantar extensor response, there are two diseases which you have to answer first. That is SACD, subacute combined degeneration of the spinal cord, and your Friedreich ataxia. Remember, this can be seen in other disorders also. For example, HIV. HIV can produce HIV myelopathy. Because of that, they can produce human type of lesion. At the same time, HIV produces neuropathy also very commonly. So combination of HIV, myelopathy and neuropathy can produce this kind of picture. Or second kind of a picture is can happen in setting of cervical as well as lumbar spondylosis. If there is a combined cervical and lumbar spondylosis also, you can get this kind of picture. But these are very rare entities. But Friedreich ataxia and SACD should be the first diagnosis whenever they ask Babinski with a absent ankle or absent ankle jerk with an extensor plantar response. So this is how your posterior cord syndrome will be presenting. But involvement of spinal cord is, the corticospinal tract is variable depending on what is the disease that is causing the posterior cord syndrome. Then we have central cord syndrome. This is really important. Central cord syndrome. How will be the central cord syndrome? So in the central cord syndrome, the central canal is the problem, and we can assume that there is some pathology that is happening around the central canal, or the central canal is basically expanding. Indra is asking how to differentiate subacute combined degeneration and the Friedreich ataxia. B12 deficiency will not have diabetes. B12 deficiency will not have cardiac involvement. B12 deficiency will not have skeletal involvement. B12 deficiency will not have family history. B12 deficiency patients can be young, but nevertheless, before diagnosing Friedreich ataxia, you have to rule out B12 deficiency also. So that's there in the criteria itself. You have to rule out B12 deficiency before diagnosing a Friedreich ataxia. But basically cannot be differentiated only clinically. You can be error prone at times. But if you want to diagnose clinically, I told you how to do it. There'll be certain pointers that are only pointing towards Friedreich ataxia, like cardiomyopathy, diabetes mellitus, and all these things. Should we look for cerebellar signs for spinocerebellar involvement? Yes, it can happen. Spinocerebellar involvement can happen, but that is not classical as far as the disease, whatever we thought is concerned. They can be there, but posterior column involvement is the classical in SACD and your Friedreich ataxia. In Friedreich ataxia, the word ataxia came from sensory ataxia, not cerebellar ataxia. It's basically due to posterior column involvement. Okay, now move on to the central cord syndrome. In the central cord syndrome, you're basically having some pathology around the central cord. You can remember like expansion of the central cord. The classic example of the disease is syringomyelia. And any intramedullary tumor also can mimic this kind of picture, but syringomyelia is the classic example of a central cord syndrome. Most important thing that will be affected in a central cord syndrome is this crossing fibers of the spinothalamic tract. That is the one that will be affected. And you know very well, as the central cord expands on the sides, you know what spinal thalamic tract fibers will be first affected. If you go to the diagram that we have drawn, spinothalamic tract is arranged from medial to lateral in CTLS kind of a pattern. So if the central cord expands, or if there is any pathology around the central canal, and if it expands, if you affect the spinothalamic tract, which will be affected first? You'll be affecting the cervical fibers first, or if you are affecting the sacral fibers first, which will be affected first? It's a very simple thing to understand, isn't it? Cervical fibers first. Okay. Cervical fibers first. This will be the first thing that will be affected. So similarly, if the central canal keeps on expanding, so at one point it can start affecting the corticospinal tract fibers also. If they start affecting the corticospinal tract fibers, which fibers will be affected first? Arm fibers will be affected first, or leg fibers will be affected first? Arm fibers or leg fibers? So arm fibers. As the central canal keeps on expanding, it will produce a descending kind of a weakness or an ascending kind of a weakness. It will produce a descending kind of weakness or ascending kind of weakness. As it keeps expanding, it's going to produce a descending kind of a weakness and not ascending kind of weakness. So that's a very important point to note here. So at early stages, if it's an early central cord syndrome, so you'll be having involvement only of spinothalamic tract only. Nothing else will be involved because that's going to involve only the cervical fibers. So that is the reason why it is also called as something called a suspended sensory loss. Why? Because only the cervical cord will be affected. So that's called a suspended sensory loss. Number one. So that word is very important. Whenever in exam, if they give you this word, suspended sensory loss, that usually indicates a central cord lesion. Apart from that, usually this sensory loss will be in the form of a cape distribution. Cape distribution. In the sense, everyone would have studied Batman's cape, isn't it? So this area is the one. So the cape, wherever the cape is there, so that is finding. So this is the first area that will be affected. That cape distribution is very, very important. So there will be initially no involvement of posterior column. No involvement of posterior column. This is a classic picture of a central cord lesion. So spinothalamic tract will be affected. In late stages, slowly, your involvement, the STT involvement will increase, and you will start having the corticospinal tract involvement also. So that's what is going to happen as the pathology around it keeps increasing over a period of time. So in the initially, like you have a limited, I should have written here basically. Initially, you have cape distribution of sensory loss. Later on, slowly, there will be a complete sensory loss. Complete sensory loss in the body. But most of the time, this pathology cannot involve the entire spinal cord. But that is the reason why any central cord syndrome, there will be one important entity. What is the last to be affected? What is the last to be affected? You are going to answer. What is the last to be affected? This is the most lateral in the spinothalamic tract. What is the last to be affected? Sacral. So that is the reason why even in late stages, the sacral fibers of the spinothalamic tract will be still spared. That's what we refer to as something called a sacral sparing. Very important. In any kind of a central cord lesion, you will result in something called a sacral sparing. Even at very late stages, the sacral fibers will be spared because they are the most lateral. And they can have bilateral weakness also. They can have bilateral weakness as well. Bilateral weakness is also absolutely possible. I mean, that is all in late stages. And remember, this weakness will follow a descending kind of a pattern. That's very, 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 very important. That will be a descending kind of a weakness. As I told you, you only told, isn't it? And we know that it's going to be a descending kind of a weakness. Okay. That pattern. All right. So in exam, what are the pointers towards syringomyelia? Suppose this is a very common disease in exam. They'll be asking you. So what are the pointers to tell that it's a syringomyelia? Usually I will tell you in exam, they will give, posterior column is spared. I told you already. There will be no involvement of the posterior column typically. You will not get involvement of posterior column. So as far as syringomyelia is concerned, in exam, usually this patient will be a heavy worker in the sense like there will be some daily wager or something, or there will be a chef. This is a usual thing in MLE exams. They'll give a chef. Whenever they give a chef, it always means it's a syringomyelia most of the times. And this person will be presenting with burns in the hands. Bilateral, they'll be having burns. So why they are telling the burns are there bilaterally in both the hands? Because of their inability to, sense the pain and temperature. Because they couldn't sense the pain and temperature. So they don't know which is hot and which is cold, and they will handle with hotter objects with much ease without even knowing that they're getting the burns. That's why usually the chef will be the usual history, because chefs are the ones who are going to handle with hot substances in the kitchen. So that's why they cleverly give the chef who's coming with burns in the hands and this kind of history. And if you see any compatible presentation like this kind of cape type of sensory loss, having a suspended sensory loss, these are the pointers towards that this patient may have syringomyelia. So that's the idea. So this history you should never forget in exam. Very important, very common. So Horner possible in this? Yes, possible. Depending on the enlargement of the cord, Horner is possible. And why, like Horner again is going to be late, but possible. It can happen. And if you ask me whether it can happen or not, definitely possible. Yes. And more importantly, this word, two other words are important even in extended central cord syndromes, descending weakness and sacral sparing. These two again are extremely important points. Cool. All right. And then fifth one. And can anterior cells be damaged here? Can anterior cells be damaged here? We didn't talk about that, isn't it? Can anterior cells be damaged? As they keep expanding, let us take that old diagram and see. So if they keep expanding, they become bigger and bigger and bigger. So can anterior cells be damaged? Yes or no? I think from this you will be able to answer. Yes or no? Yes, of course, anterior cells will be damaged. But remember, anterior cells will be typically involved at the level of the lesion only. So because this syringomyelia is extremely common at the level of cervical spinal cord, it's not common at the thoracic spinal cord. Very commonly, syringomyelia is common at the level of the cervical spinal cord. Very commonly, syringomyelia will also have another history, that is wasting of the small muscles of the hand. And it will be bilateral because central cord syndrome will be symmetrical. They're going to expand bilaterally. So there will be bilateral wasting of small muscles of the hand. Small muscles of the hand. So that is also one important history that is compatible, because at that particular level, the anterior cells will be damaged. Because of that damage, you might be seeing bilateral wasting of the small muscles of the hand, and the patients will show fasciculations also. Whenever you see the word fasciculations in exam, it always means some damage to the anterior cells is there. That's all. Any damage to the anterior cell will produce a sort of fasciculations. Very, very important point again. So fasciculations directly means anterior horn cell damage. That's all. Okay. So they can get Horner syndrome. If you ask whether Horner is compatible or not, yes, it can happen in late stages, in syringomyelia and in central cord syndrome. Then we have, we have studied central cord syndrome, subacute combined degeneration, Friedreich ataxia. Yes, absolutely fine. Then there is a separate kind of presentation called ALS, amyotrophic lateral sclerosis, which we'll be discussing separately. So these are the 4 important presentations. So one is the Brown-Sequard presentation. Second is the anterior spinal presentation. Third is the posterior cord syndrome, posterior cord kind of a presentation, which is very common in demyelination disorders. Next is the central cord syndrome, which is present in 2 things. One is syringomyelia and intramedullary lesions. Cauda equina. Cauda equina is completely different. You should not think about cauda equina now. That's a nerve root problem at the end of the spinal cord. So now based on this, we can try to answer 2 things. One is going to be the extramedullary spinal cord lesions, and second one is the intramedullary spinal cord lesions. How can you differentiate an extramedullary spinal cord lesion versus an intramedullary spinal cord lesion? So this is also a very common question. So first of all, let us take the spinal cord like this. So to understand extramedullary, let me shade it in, let me put it in red. Extramedullary lesions will come outside the spinal cord, from outside the spinal cord, isn't it? So usually there will be tumors. So they're going to compress from the outside like this, extramedullary. As far as intramedullary is concerned, you can imagine like a central cord lesion. So that's how they're going to mimic. So, which means first thing, the basic understanding, extramedullary lesions, they're going to compress from the outside, whereas intramedullary lesions are going to mimic a central cord lesion. So this is, for both these things, the most common thing is the tumor only. Tumors are the ones that are going to produce this both. But on the other hand, if you take a extramedullary finding, if you talk about the pain, it will be very early symptom, because from the outside, if you compress, there is a lot of possibility that the roots will be compressed, the nerve roots will be compressed. So it's going to be extremely early because they compress from the outside. And it will be more of a root kind of a pain. As far as intramedullary is concerned, because the spinothalamic tract will be the usual things that will be affected first, the root pain will not be. Only when you compress the dorsal root ganglion, you will get a sort of a root pain. If you don't compress the dorsal root ganglion and only spinothalamic roots are disturbed, that can result in sort of a pain, but it will be kind of a vague kind of a pain. Pain will be a little late here, and they will not get that classical sharp root pain that you get in extramedullary compression and root compression. They will be more of a vague and kind of a burning pain and very poorly localized. Actually, this is called as a funicular pain. These are the words that are used to describe this kind of pain. So that's a vague kind of a pain. It will be burning, it will be more deeper, and it will be poorly localized and called as something called a funicular kind of a pain. And as far as the sensory deficits are concerned, so you can imagine this extramedullary like sort of a Brown-Sequard syndrome, where they're going to cause hemisection of the spinal cord. So what you will get in a Brown-Sequard syndrome? So on the ipsilateral side, you're going to have loss of posterior column sensations like proprioception, vibration, light touch, position, and all this stuff. So on the contralateral side, you're going to lose the pain and temperature. There will be loss of pain and temperature. And this loss of pain and temperature, the pain and temperature is what we're talking about. So when you go, it will be kind of an ascending or descending. So let us go back and see. Loss of pain and temperature. If you compress from the lateral, so this is an extramedullary lesion. If you compress from the side, it will be like an ascending kind of a lesion or a descending kind of a sensory loss. Ascending or descending? From side if you compress. Yes, of course, you're right. So because you're compressing from the side, you're going to have some kind of an ascending kind of a sensory loss. That's a very important point here. On the other hand, if you take the sensory deficit here the posterior column will be completely spared here. In the sense, like I can write the posterior column as spared. There'll be no problem in the posterior column. And there will be bilateral loss of pain and temperature because it's a central cord. it will be more symmetric in nature. And in central cord syndrome, we saw a sort of ascending or descending kind of sensory loss. What we saw in the in the central cord syndrome, we already discussed in syringomelia. Descending or ascending? Descending or ascending, man? Yes, you are going to get a sort of a descending kind of a sensory loss. And more importantly, there is one more area that will be spared, I told you. What will be there? What will be spared in the central cord syndrome? Yes. So this word is very important again. So this word called sacral sparing will tell you that it is probably a intramedullary lesion, not an extramedullary lesion. Yes, there will be a typical sacral sparing. And as far as the motor deficits are concerned, we know probably like a brown sea cord, if you think about, there's going to be prominent human type of an involvement. Prominent human. And more often, the legs will be affected early, or your arms will be affected early. Which will be affected early? In a brown sea cord, or when you are compressing from the side, which will be affected early? Legs or arms? In extramedullary lesion. So yes, your legs will be affected early. It will be prominent human kind of a picture, and legs will be affected early. Most often it will be asymmetric, because from one side only it's compressing. Yeah, STD involvement will cause a kind of a funicular pain, and that is due to aberrant transmission of impulses to the thalamus, because there should be some sort of transmission of this aberrant signals, isn't it? Otherwise, how it will, you can imagine like you can cut the cord. That is different. In ischemia, when it is damaged, that loss is different. But when it is compressed, that will be different. So there will be, I don't know, that's a completely separate physiology I have to explain. There will be transmission of signals called as axonal block type of signals, which will be completely transmitted different way to the thalamus, and they will cause that kind of a dull funicular type of a pain. That's what happens in STT compression. But loss of, STT, this thing is different. You're cutting the STTs, that is completely different, or ischemic STT affection is different, but this is different. Here it's compressive lesion. So that's why you're talking about a different kind of a pain. So motor deficits, prominent human, legs affected early, and more often it will be asymmetric in nature. On the other hand, if you take the central cord lesion, in a central cord lesion, let us go back to our original diagram and see. So which will be basically affected first? Your anterior horn cells will be affected first, or your lateral corticospinal tract will be affected first? Basically by the common logic. So when they keep expanding, which will be affected first? Anterior horn cells or the lateral spinothalamic tract? Yes, anterior horn cells will be affected first, which means if the anterior horn cells are affected, it will be prominently human or prominently element if your anterior horn cells are affected. If then it's a nucleus. So yes, there's going to be prominent element type of involvement here. And usually it will be bilateral, because central cord lesions will not produce asymmetricity. So usually it will be bilateral. And many students do ask me, sir, you're told asymmetric. So, and you told Brown Sequard syndrome. So if you tell Brown Sequard syndrome, how can it involve the other side? So it should only involve this particular side, right? So why it should involve the other side? If you ask that kind of a question, it's very simple. So remember, this spinal cord is not only compressed from this side, this spinal cord is also going towards a tremendous pressure on the other side, because there is something called a spinal cord, that's a fixed space. Once it compresses from one side, it goes to a tremendous compression on the other side also, which means you can involve the other side tracts also to an extent. I'm not telling to a great extent, to some extent other side tracts also can also be involved. Because of that, you can get bilateral weakness sometimes. And that is the reason why you get this kind of asymmetric involvement. At the same time, because of the other side nerve root compression also, you can get pain on the other side, but even that pain will be more often asymmetric in nature. Whereas central cord syndrome, the characteristic feature is, in fact, the intramedullary lesion characteristic feature is, it more often tries to produce a kind of symmetric picture. So that is what all about the intramedullary lesion. Anyway, it will be more prominent and it will be bilateral in nature. and which means they will be showing more of atrophy and fasciculations. As far as the bladder involvement is concerned, bladder and bowel involvement, we are talking about incontinence here. Bladder and bowel involvement is a little late, whereas in intramedullary lesions, it's going to be extremely early. That is because next to the anterior horn cells, you have a type of nucleus called as Onuf nucleus. Onuf nucleus is the one that basically supplies the motor function to the bladder and the bowel. If that Onuf nucleus is damaged, which is present next to the anterior horn cells, you can get very early bladder and bowel involvement. Clear? So these are the basic differences between an intramedullary lesion and an extramedullary spinal cord lesion, which is very important again for your exams. Most of the time, they will give a pattern in exam. They'll ask you to find out whether it's an intramedullary lesion or an extramedullary lesion. Remember, it's very difficult to know the causes because so many causes will be overlapping. Same lesion can produce intramedullary lesion as well as extramedullary lesion. But nevertheless, it's very important to understand. So whenever the key points in exam is, see, sacral sensation is different. Keshav is asking if bilateral sacral involvement is early, then why bladder and bowel involvement will be late? I mean, I told here sacral involvement will not be there, which means we're talking about a sacral sparing here, but it doesn't mean that sacral involvement is early here. So we talked about a kind of an ascending kind of a sensory loss only, but there will be no sacral sparing. And at the same time, you are actually confusing with your cutaneous sensory loss with the motor problem, which is completely different. Bladder involvement, you're talking about a motor issue, where the Onuf nucleus that is next to the anterior horn cells is the one that supplies the bladder, and you're comparing that motor problem with the sensory tract that is present in the lateral side, the lateral spinothalamic tract, and you're comparing that with the motor problem of the anterior horn cell and the Onuf nucleus that is present actually on the medial part of the spinal cord. So that's completely different. So I don't think there should be any sort of confusion there. So, I mean, in the sense like, yes, to start with, these confusions are quite common and overall you will get better. But nevertheless, clinically, so the sacral sparing and this kind of funicular pain, the word funicular, sacral sparing, then prominent LMN, atrophy fasciculations early. So these are the things that are going to be early bladder and bowel involvement. These are things that are going to tell it's a, what is that, intramedullary kind of lesion. And if you hear prominently this word kind of asymmetric Yeoman type of lesion, more of a root pain, which happens extremely early, then more of a ascending kind of a, sensory loss. So if you hear these kind of things, especially the bladder and bowel involvement is late. So in that setting, you will be thinking more of a extramedullary lesion. And among all these things, if you take the most important point among all these things, if you want to tell one point that is important in exam, that will be very, very useful to differentiate between intramedullary and extramedullary, it's going to be the bladder and bowel involvement. That's going to be the most important. Bladder and bowel involvement is going to be the most important. Remember, whenever you talk about extramedullary, then as Riju is asking now, you have extradural as well as intradural lesions. There is a difference in that. And at the same time, when you talk about extramedullary, there is something called a conus medullaris lesion versus cauda equina lesions also. All these things have to be differentiated, but I'm not going to talk about that right now because it will be too much right now. So at the end of the spinal cord discussion, we'll be discussing about how to differentiate a conus medullaris versus cauda equina lesion and how to differentiate between, if there is time, I'll be discussing about how to differentiate between an extradural and an intradural lesion. So that is also there. But to start with at a beginner level, to know stuff that is extramedullary versus intramedullary, this table is most important. So in exam, most of the questions will be revolving around this particular table only. Because once I'll complete the disorders, then I'll be discussing about dural differentiations and your conus medullaris versus cauda equina. And if you keep on going, it will be keeping on going because there is something called epiconus and all. There is epiconus lesions are there. So that is too much again. So that is not, this level of discussion doesn't need warrant all those things. But anyways, nevertheless, one more disease that we need to discuss is on the motor neuron diseases, which can affect the spinal cord well. So motor neuron disease means these disorders affect only the motor neurons, as the name suggests. So once you know that these disorders are going to affect only the motor neurons, you also need to know that what are the motor neurons and where are the motor neurons. So motor neurons can be either upper motor neurons or lower motor neurons. Upper motor neurons are basically the bed cells and the lower motor neurons are basically the anterior horn cells. When you take the bed cells, that is the upper motor neurons, and there are some motor neuron diseases which affects only the bed cells. Affects only the bed cells, will have only human features only, and that disease what we refer to as something called a primary lateral sclerosis. That's called a PLS, primary lateral sclerosis. And there are some disorders that affect only the anterior horn cells, affects only anterior horn cells, which means they will be pure element features only. There are many disorders that can affect the element neurons, anterior horn cells alone. But one of the important genetic and neurodegenerative disorder example is spinal muscular atrophy. That's an SMA. But there are many disorders. Can you tell one infectious disease that affects only the anterior horn cells, producing a motor neuron disease? What is that infectious disease? Rabies does not affect only the anterior horn cells. Rabies affects so many areas. Rabies is wrong. Polio. And apart from that, I mean, polio is very rare nowadays, isn't it? Acute flaccid paralysis. You have something called West Nile myelitis, West Nile virus. I'm just telling examples. West Nile myelitis. So West Nile, polio, all these things are classic examples of anterior horn cell involvement only. So that is why these are motor neuron disorders again. So remember, SMA stands for spinal muscular atrophy. Somebody is asking what is SMA. SMA stands for spinal muscular atrophy. And there is some disorders which can affect both bed cells as well as anterior horn cells, which means these disorders are going to have human as well as element involvement in a particular patient. And when a disorder affects both this human as well as element, that disorder is what we refer to as ALS, that is amyotrophic lateral sclerosis, otherwise referred to as Lou Gehrig disease. And you can also call this as Stephen Hawking disease because Stephen Hawking died of amyotrophic lateral sclerosis only, and it has both human as well as element features. That's very classical of an amyotrophic lateral sclerosis. If they ask you the most common MND in the world right now, that is amyotrophic lateral sclerosis only. MND that is most common in the world, amyotrophic lateral sclerosis. And if you want to know other disorders that can produce this kind of primary lateral sclerosis like phenomenon, let me put in the same this thing. What are the other disorders that can produce PLS like picture? For example, these are very important because PLS is a rare disorder. It's not a very common disorder. So they will definitely ask you what are the other differential diagnosis for a PLS like picture. One is lathyrism. This is my professor's favorite. Lathyrism, every time he asks this, lathyrism does the same thing. There is another disorder called adrenomyeloneuropathy. This is another differential diagnosis, second differential diagnosis. Third one is we have something called HHV8 infection causing it produces a disorder called as HTLS, tropical spastic paraplegia. I'm sorry, HHV8, and there is another this thing called HTLV virus, human T cell lymphotropic virus. This produces a disorder called tropical spastic paraplegia. And these are common disorders. So lathyrism, adrenomyeloneuropathy, HHV8, and HTLV, that is human T cell lymphotropic virus, which produces a typical disorder called as tropical spastic paraplegia. So these are the differential diagnosis and the more common differential diagnosis. As far as spinal muscular atrophy is concerned, you have poliomyelitis, you have West Nile myelitis, then you have other disorders also. Like for example, other DDs that you can remember for this is, there is something called a Kennedy disease. I'm going to discuss about Kennedy disease in some time. That's called a X-linked bulbospinal atrophy. That's called a Kennedy disease. And then we have a multifocal motor neuropathy. These are differential diagnoses. Multifocal motor neuropathy. So the DD for PLS, Lathyrism adenomyeloneuropathy, HHV8 and HTLV related tropical spastic paraplegia. And DD for spinal muscular atrophy is poliomyelitis, Westernal myelitis, Kennedy disease and multifocal motor neuropathy. And the DD for ALS. Usually DD for ALS is not that common, but there are some 2 DDs which you need to tell. ALS. This is more important. So even if you forget those things, these things you should not forget. Can anyone tell what is the most important DD for ALS? Very common DD. And you won't believe if I tell that. What is the DD? The first DD, if they ask you, what is the DD for ALS? I'm not getting an cervical spondylosis. I'll tell you why cervical spondylosis can mimic an amyotrophic lateral sclerosis. Cervical spondylosis is the first DD that you have to tell. And second DD for ALS is Makada-Joseph disease. And these are new terminologies, Makada-Joseph. So Makada-Joseph is basically a SCA3, that is spinocerebellar ataxia type 3, which will have pyramidal features also. Along with that, they will have ataxia. It's one of the closest DD for amyotrophic lateral sclerosis, Makada-Joseph disease, spinocerebellar ataxia type 3. So why this Makada-Joseph is important? Because that spinocerebellar ataxia type 3 is supposed to be the most common type of spinocerebellar ataxia in the country, in India. Because spinocerebellar ataxia, there are 30 to 40 different types of spinocerebellar ataxia. In that, this SCA3 is the most common type of spinocerebellar ataxia in India, where they will show human element features will be there. Along with that, cerebellar problems also will be there. But as a whole, there are some no's in MNDs. What are the no's? There are some things which cannot be seen in motor neuron disease. The first no, the name tells it is a motor neuron disease, which means there should be no sensory involvement. When there is a sensory involvement, then you can rule out these disorders. None of the differential diagnosis is also possible. So number one, no sensory involvement because it's a motor neuron disease. And second, there will be no bladder and bowel involvement. Students might be asking why there is no bladder and bowel involvement. Because I told you the motor sensation to the bladder and bowel is carried out by a separate nucleus called Onuf nucleus, and only the anterior horn cells will be damaged here. The Onuf nucleus most of the times will be completely spared. So which means the motor to the bladder and bowel will be spared. So the bladder and bowel involvement will not be there in majority of these disorders. And third no is due to some variety of weird reasons, they will not have extraocular muscle involvement, which means even after the spelling of the nucleus is Onuf, O-N-U-F, Onuf nucleus. So that's what we're talking about. Okay. So even if the entire, like your bulbar paralysis will be there in this patient, the 9, 10, 11, 12 will not be working. The, what is that, 7th cranial may not be working. The face will be paralyzed. But one thing that will not be lost and it will be perfectly working is the extraocular muscles. Due to variety of reasons are there. Extraocular muscle involvement is not a feature of a motor neuron disease. At the same time, no higher mental function involvement. No higher mental function involvement. So this is also a very important point, which means most of the time, dementia is extremely rare in this motor neuron disease. They don't develop dementia, which means memory will be perfect. You can imagine Stephen Hawking itself. He was publishing papers even before his death. So there is no memory involvement. Even though I'll be talking about FTD-ALS complex later on, where there can be association with some form of frontotemporal dementia. But right now, as a common understanding, there should be no sensory involvement, no bladder and bowel involvement, no extraocular muscle involvement, and finally, no higher mental function involvement. All these four are very, very important as far as motor neuron diseases are concerned. So remember, we need to talk about amyotrophic lateral sclerosis in detail. So which will be the most important form of motor neuron disease, and that will be the question in the exam as well. First of all, we know what is motor neuron disease. It is a Lou Gehrig disease. And of course, it's neurodegenerative disease. Neurodegenerative disease in the sense like there is due to some reason, we don't know why, majority of neurodegenerative diseases, we don't understand the reason. Due to some reason, the neurons are going for degeneration. What neurons are going for degeneration? We know the bed cells, due to unknown reasons, they're going for degeneration. and the anterehorn cells, due to unknown reasons, they are going for degeneration. And second basic point that you need to know is, whenever you talk about neurodegenerative disorder, there will be some signs of degeneration, which means there will be some inclusion body that will be accumulating within the particular neuron that is going for degeneration. What is the inclusion body that is seen here? Everyone should be good in pathology, so you should be able to tell that. What is the inclusion body? Because in any neurodegenerative disorder, you should have some inclusion body that is accumulating. So what is the inclusion body that is seen here? No idea. There will be something called a Bunina bodies. Like in Alzheimer's disease, you are seeing this neurofibrillary tangles. I mean, a lot of entities, like you are seeing different bodies, isn't it? Pig bodies are there. Like that, this is also neurodegenerative disease, but the characteristic body that have been described in amyotrophic lateral sclerosis, Bunina bodies. Basically, it's a disease with not a very good prognosis. If they ask you the average survival from the time of symptom onset, from symptom onset to death is usually 3 years, and from the time of diagnosis to death is usually 1.5 years only. So this is the usual like survival. But even though there are some extreme cases like Stephen Hawking who has survived for like decades together, so that's completely different. I'm not talking about the variations there, because ALS itself has a lot of variation, like Mills variant is there, Flaylam variant is there, then even Madras motor neuron variant is there. So many variants are there. I think there are 13 to 15 variants of ALS is there, and that is beyond the scope of the current discussion. And these Bunina bodies, if they ask you where you will see, you will be seeing horn cells. So that's characteristic. This is a question. Bunina bodies. And clinical feature wise, and before that pathophysiology. Pathophysiology wise, there's not much to be pondering about. So there is one mutation we thought that could be the probable reason for development of amyotrophic lateral sclerosis. That is copper zinc superoxide dismutase 1 mutation, SOD1 mutation. Very common question in exam. Copper zinc superoxide dismutase 1. Saurabh is asking where? In anterehorn cells, AHC. These Bunina bodies are prominently located in the anterehorn cells. That's what we're talking about. Anyways, pathology is mutations in the SOD1, copper zinc superoxide dismutase 1. As far as the clinical features are concerned, the patients will be having combined features of human element, which means certain areas will show human involvement, certain areas will show element involvement. We know what do you mean by human involvement. The deep tendon reflexes will be exaggerated, and there might be spasticity. The limb will be completely spastic. Usually they'll show something called a Klasner spasticity, and plantar may be extensor. Babinski positivity will be there. And the same patient may have element features in some other areas. For example, the DTS will be absent or sluggish in some areas. They'll be having atrophy, and they'll be having fasciculations. As I told you, fasciculations are one of the key features of anterehorn cell damage. So they might be having fasciculations, and they may be having a lot of other features also. But remember, if they ask you the first symptom in a patient suffering from amyotrophic lateral sclerosis, that's going to be fasciculations. This is the first and the earliest sign of amyotrophic lateral sclerosis, because the anterehorn cells are damaged here. That's going to be one of the preliminary and the primary findings of ALS. So fasciculations. Many times these fasciculations can be mistaken for cramps by the patient. And sometimes in exam, to confuse you purposely, they will give the patient is telling cramps all over the body. When you examine, the patient is having Babinski positivity, and the right limb looks atrophied. So this kind of clinical picture they will give. So here the cramps doesn't mean it's cramps, it's actually fasciculations. That's how the patients will tell you, because patients can't tell you I'm seeing fasciculations everywhere. Clear? And bulbar weakness is extremely common in majority of these patients. Typically, bulbar weakness is seen in approximately 20 to 40% of the individuals, but almost half of the patients will exhibit some form of bulbar weakness will be there. Clear? And this can be seen in the same limb also. For example, take a lower limb. Lower limb is the best example, where that particular lower limb may be completely wasted, which means it will be totally atrophic, showing fasciculations in a lot of areas, which are signs of LMN. But if you try to, because in an element, the tone should be lost, isn't it? So if you try to check for the tone of that limb, the tone will be too much. So you see you are confused, like the atrophy with fasciculations, but actually the patient is spastic. And when you do a Babinski, it will be showing a plantar extensor, and deep tendon reflex will be very brisk. So same limb having atrophy, fasciculations, but exaggerated DTRs with Babinski positivity and spasticity. So this is a sort of a confused kind of a scenario. So whenever you see this kind of UMN and LMN in the same patient, then it's going to be a concrete diagnosis of an amyotrophic lateral sclerosis. But remember, same limb if you have UMN or LMN may or may not be there. Picture similar to Friedreich ataxia and SSCD. No, if Friedreich ataxia and SSCD, you are getting a different picture. That's not a kind of a picture. In Friedreich ataxia, you don't develop fasciculations. Where are fasciculations in Friedreich ataxia and subacute combined degeneration of the spinal cord? It's a demyelinating disease. Remember, anterehonsal damage only will result in fasciculations. Peripheral nerve damage will result in fibrillations only. Fibrillations cannot be seen visibly. So that's why that fasciculations is a very important word as far as ALS is concerned. And as far as your Friedreich ataxia and your subacute combined degeneration of spinal cord is concerned, you'll have prominent posterior column involvement. Posterior column involvement will be extremely prominent. So if you have prominent posterior column involvement, you will have loss of vibration, position, all these things. Here, one important thing that tells you that it's a motor neuron disease, patient should not have any sort of sensory involvement. Then how can you, in fact, even equate this with subacute combined degeneration of the cord? If you open this kind of things to the examiner in YOC, they'll get extremely irritated and angry. Whenever you tell ALS, if you have a sort of amyotrophic lateral sclerosis like of scenario, you should tell these kind of sensible differential diagnosis like Makata-Joseph disease, then cervical spondylosis. That might be agreed. But if you tell SACD and all, especially in YOC kind of scenario, they might get really pissed off because that's a completely different thing. Whenever you have a sensory loss itself, that completely goes against the amyotrophic lateral or any motor neuron disease for that matters. That's why whenever you open your mouth, especially if you're a final year and you're going for some practical exam, you should be very careful in opening your mouth. So whenever you commit something, you commit only if you are very, very sure. Because when you don't commit anything, sometimes you might pass. But when you commit something and if you're blabbering something, that's the end of you in the exam. So be very careful about that. When you're extremely sure, commit something. Okay. So there are a lot of variants are there. For example, Mills variant is there. You have flail arm variant is there. Like told, Madras motor neuron variant is there, which is beyond the scope of the discussion. So let us go for the investigation. Is there any investigation that can confirm ALS? No. ALS is basically a clinical diagnosis. Sometimes it might take years to diagnose ALS. I've seen so many people diagnosing ALS as cervical spondylosis in the beginning to start with, because MRI will show some element of spondylosis in everyone. Motor neurons and all, how Babinski will be positive. Corticospinal tract should be involved for positive Babinski. Yes, of course. I mean, for that I should, Alex is asking how Babinski will be positive. I'll ask one question. So where corticospinal tract is originating from? Where corticospinal tract is originating from, Alex? Please answer first. Cortex. In the cortex, which group of cells? Bed cells. Yes. I told you, right? Bed cells are involved here. We discussed, right? Bed cells and AHCs both are involved. So that's why you have a human and element. Fine. Okay. Investigation. So clinical diagnosis, first of all. Then you can do investigations to rule out other possibilities. For example, MRI of the cervical spine may be necessary, or MRI of the entire spinal cord may be necessary to rule out any tumors in case, some compressive lesions in case, that's all. Then electromyography to rule out muscle disorders and neural disorders and nerve condition studies to rule out peripheral neuropathy. So these are done only to rule out other possibilities, but I mean, once you rule out all the other possibilities, then this kind of picture must be ALS only, and that's basically a clinical diagnosis. And you might ask how cervical spondylosis can produce ALS-like picture. Very simple. In a cervical spondylosis, the spondylotic fragments will compress the spinal cord and they can compress the brachial plexus also. So once they compress the brachial plexus, they will produce element of the upper limb. So they'll have a feature similar to element of the upper limb. Once they compress the spinal cord, they can produce UMN of the lower limb. That's all. Depending on, I mean, there's a possibility. So they can, spondylotic fragments can compress the spinal cord producing UMN of the lower limb, and they can compress the brachial plexus causing LMN of the upper limb. So which means again you are getting LMN and human feature in the same patient, where you can think about a amyotrophic lateral sclerosis kind of a scenario. But more importantly, there will be some distinct features that will be present in cervical spondylosis, which may not be seen in amyotrophic lateral sclerosis. Number one is the sensory involvement. Remember, whenever you talk about a spinal cord involvement, there will be a typical sensory level. So whenever you have a transection of the spinal cord or a compressive lesion of the spinal cord, we are talking about above the lesion, below the lesion. So I told you many areas, contralateral pain and temperature loss below the level of the lesion. What do you mean by below the level of lesion? You are actually talking about a sensory level. Whenever you tell below the level, above the level, that sensory level is there means that level is equal to a spinal cord lesion. That's all. So sensory level will be there most of the time when you compress the spinal cord. So that kind of sensory level will not be there. And prominently, they will be having root pain. Neck pain, root pain is extremely common in the setting of a cervical spondylosis. But neck pain, root pain and all can be there in amyotrophic lateral sclerosis patients also due to a variety of reasons, but that will not be prominent, not the only complaint in ALS patients. Number three, very commonly, bladder and bowel involvement will be there in late stages. I mean, not early stages because it's a compressive lesion, extramedullary type of a compression. So usually it will happen, but it will happen a little late. So, but still, bladder and bowel involvement may be there in the setting of a cervical spondylosis, but not a must. But if it's there, definitely it goes against amyotrophic lateral sclerosis. Number four, there will be no bulbar involvement or there will be no cranial nerve involvement in the setting of a cervical spondylosis. Why a cervical spondylosis should cause a cranial nerve palsy or a bulbar palsy? Because it's happening in the cervical spinal cord. So, motor neuron disease patients and in fact ALS patients very commonly will have bulbar involvement. So remember, anytime in neurology, whenever you practice neurology, you should not look for all the features. You should look for features that may be present or may not be present. It's like a selective thing. Maybe only one may be telling you that it's not ALS and it's a cervical spondylosis. Maybe only one fact may be telling you that it's a ALS, not a cervical spondylosis. So you look for all the features and compare and contrast and see, give the weightage and finally make a clinical diagnosis in neurology. That's how we're going to make. So the most important DD is cervical spondylosis basically, and you need to know why cervical spondylosis is a very important DD. And as far as the treatment is concerned, so treatment for ALS, you have multiple drugs that are available that are approved. Currently approved drugs are two. One is called riluzole, which is going to be a NMDA receptor modulator. Remember, many books will tell you NMDA receptor agonist, NMDA receptor antagonist, but remember, more often riluzole is considered to be NMDA receptor modulator rather than agonist or an antagonist. So riluzole, one problem with riluzole is hepatotoxic, so you have to monitor the LFTs, number one. Second problem is it is not very effective drug. It's going to improve survival by 3 to 6 months only, which means if the patient with amyotrophic lateral sclerosis is going to live for 3 years, riluzole will make the patient, giving riluzole for 3 years will make the patient live for 3 years and 3 months or 3 years and 6 months. So not a big survival benefit, but still this is a drug that is approved. Second drug that is approved is edaravone, and the mechanism of action is completely not understood, but still it's considered to be a neuroprotectant like citicoline, which are using very commonly in our practice. So edaravone, this is the second drug that is approved in amyotrophic lateral sclerosis. But apart from the drugs, you can prevent death to large extent in amyotrophic lateral sclerosis if you understand the pathophysiology. I mean, you understand the reason for death. Remember, most common cause of death in patients with ALS is, of course, respiratory failure. Everyone knows that. Once the diaphragm is paralyzed, getting weak and weak and weak, you will get a type 2 respiratory failure typically, and the patient is going to die. So that's the usual cause of death. To avoid respiratory failure, there is a trial that is done on nocturnal BPAP. BPAP is a type of a non-invasive ventilation. So this nocturnal BPAP has better survival compared to that of using riluzole and edaravone. Riluzole can increase the survival only by 3 to 6 months, but if you consistently use a nocturnal BiPAP to prevent death, that can improve survival by years. So clearly, rather than treating this disease, it's better to prevent the death in this disease. That's going to be better. So if you ask me the best intervention to prevent death, I will always go for nocturnal BiPAP only, not for the drugs, because that is the best intervention to prevent death in these patients. Riluzole, I don't think it's a very good drug, very costly, orphan drug. It's not available, highly hepatotoxic. So not a very good drug in this setting. But still, for exam sake, you can remember riluzole and edaravone. But for practice sake, I don't really use riluzole. We have some group of ALS patients in Chennai itself, where you have separate ALS societies there separately. There are some 15 to 20 patients are there. Anyway, they help each other, and nobody is getting actually riluzole, to be precise. And there are some variants of ALS. I'm not talking about the motor variant. We are talking about the dementia variant. For example, there is ALS FTD complex is there. That is a frontotemporal dementia complex. Then ALS Parkinson complex is there. So which means ALS can be associated with Parkinson disease also. I told you usually MND will not have any IQ problem, but very rarely ALS can be associated with frontotemporal dementia if the inclusion body is made of TDP43. Some TDP43 related inclusion body variants can be having both FTD as well as amyotrophic lateral sclerosis. And this ALS Parkinson variant is what we refer to as ALS Parkinson variant of Guam. The name is ALS Parkinson variant of Guam, where they can be associated with Parkinson disease also. So after this, let me tell you about how to differentiate between a human lesion, how to differentiate with an element lesion, and to differentiate that with a neuromuscular junction lesion, to differentiate that with a myopathy, muscle lesion. So how will you differentiate each and everything as a sort of a differential diagnosis? Number one, first you need to show the distribution of weakness. Distribution of weakness. Based on the distribution of weakness, human will have a characteristic distribution. Typically, I will be calling it as an extension. I mean, extensors of the upper limb and the flexors of the lower limbs are the ones that are maximally affected. How you can understand this basically? First is you can remember the patients who are seen in the movies, or remember a typical stroke patient. Whenever in movies you talk about a typical stroke patient, you will imagine someone like this. Why they are like this? Number one, because corticospinal tract is not there now. Because corticospinal tract is dysfunction in that particular limb, rubberospinal tract and the other extrapyramidal tracts will take over, and the arms will go for flexion and adduction. Which means this is what you have been in the past, isn't it? When you are when the corticospinal tract is underdeveloped, your arms have been actually flexed, and it is basically trunk is also flexed. So that's how the patient goes. So because if we don't do any physiotherapy, slowly the other extrapyramidal tracts will take over, and slowly the rubberospinal tract on the upper limbs action is too much once the corticospinal tract is gone. So they're going to flex the upper limb, and you're going to get a flexion kind of a spasticity. I mean, like this. And which means the basic function of the corticospinal tract should be something else. So you can imagine like it should actually extend the limbs, and it should basically abduct the limbs. So adduction and flexion is basically rubberospinal tract's activity. So corticospinal tract should overpower the rubberospinal tract under normal conditions. So it should be extension and abduction. So that is very, very important. So I can tell in the upper limb, the main function of corticospinal tract will be extension of the upper limb and the abduction of the upper limb. So which means if they ask you about the distribution of weakness as far as the corticospinal tract or any human lesion is concerned, the most important area that will be weak is extensors of the upper limb, because that is a basic supply of the corticospinal tract, extensors of upper limb, and abductors of the upper limb. Abductors of the upper limb. So this is very, very important. And as far as the lower limb is concerned, typically they are going to be the weakness of the flexors of the lower limb. So this is also important for one of the signs that you see in human lesion, that is called circumduction gait. Why you see a circumduction gait? So you would have understood that circumduction gait is classically the limb will be like this, but they'll rotate the limbs outward and come and keep the limb. So whichever limb that is affected. So why you get circumduction gait? Because these patients will have weakness of the adductors of the lower limb and the flexors of the lower limb. Because they cannot flex the limb properly while walking, every step you take, you flex and then you keep, then you extend. Then you flex, then you extend. So this is how you basically walk. Suppose if you have weakness of the flexors of the lower limb, your limb will be in extension and you cannot flex, to be honest. So once the limb is in extension, now you cannot, like move straight, because of course you will be dragging the limb otherwise. So because the limb is straight and it cannot be flexed, the lower limb, you need to turn the limb towards the outer side, because here the adductors are also a little weak. So you have to use the abductors to go towards the outer side and then come back and keep the limb like this. So this is what we call it as a classic circumduction gait. So whenever they ask in exam, what is the typical distribution of weakness as far as the human palsy is concerned, you should tell extensors of upper limb and flexors of the lower limb. This is, if you give this answer, everyone will be too happy. Extensor upper limb and flexors of the lower limb. And this is the reason why you see this kind of paralysis if you don't treat with physiotherapy, or this is the reason why you see this kind of circumduction gaits. Everything can be explained with that particular distribution of weakness. And as far as the element is concerned, usually element weakness will be more distal, involving the small muscles of the hand, usually more distal, and it will be segmental in the sense like whenever a particular peripheral nerve is affected, you will be seeing weakness only in that distribution of the nerve. For example, median nerve means only certain muscles in the hand will be lost. Ulnar nerve means only certain muscles in the arm will be lost. Radial nerve means only certain muscles, extensors, wrist drop will be there. So which means it's more of a patchy, segmental kind of an involvement. So it usually tells you a element kind of a weakness. As a neuromuscular junction kind of weakness, one important clue will be they'll be affecting ocular muscles. So whenever you have a prominent ocular involvement, think about a neuromuscular junction weakness like myasthenia gravis. At the same time, there'll be more of a proximal weakness, and they won't be symmetric at all. It will be more asymmetrical in nature. Asymmetrical. If you talk about myasthenia gravis, it will be more of asymmetrical weakness only. Yeah, Indra is telling intermittent weakness, but more than intermittent weakness, the right kind of word will be a fluctuating weakness. Fluctuating weakness, that will be more correct rather than an intermittent weakness. And easy fatigability. So these kind of clues that goes towards a neuromuscular junction weakness. So in exam, whenever you get the word called fluctuating weakness, it is likely to be an NMJ involvement. As far as myopathy is concerned, ocular is rare. In a pure myopathy, you will really not get ocular involvement very prominently. And here also there will be proximal weakness more than distal weakness, even though there are some muscle disorders where distal weakness will be more than proximal, but more often proximal weakness will be prominent. Okay, I'll write only proximal. But more importantly, they'll be symmetric. They'll not be asymmetric. They'll be symmetric. So this is to differentiate between neuromuscular junction and muscle problem, myopathy. And next you have atrophy. Atrophy. Atrophy is basically not a feature of human lesion, but it can be seen in late stages due to disuse atrophy. In very late stage, if you don't use the limb at all, disuse atrophy may come, but the disease per se does not produce any atrophy. But atrophy is a very, very prominent feature of a element. We know that. And at the same time, atrophy is not a feature of NMJ. And again, atrophy is not a feature of myopathy also. In very late stages, there can be a mild atrophy, but atrophy is typically not a feature. And as far as fasciculations are concerned, definitely fasciculations are not a feature of any of these disorders. Fasciculations are a feature of only element lesion. Typically, it's telling you that the patient is having an anterior horn cell damage. That's what fasciculations are all about. Then you have tone of the muscles. Tone, of course, it will be increased in the setting of a human lesion. That is what we refer to as a clasp knife spasticity. And as far as the LM is concerned, the tone will be decreased. We call that as flaccidity. And the tone will be normal in NMJ and myopathy. So that's very important. In the late stages, there can be mild reduction can be there. That only mild reduction, not severe reduction. But apart from that, as far as exams are concerned, you should tell only tone is normal in the setting of myopathy. So that will be completely normal. These are very important differences. Then what about the Babinski? Plantar extensor is a strong feature of a human lesion. It's never seen in the setting of element lesion or muscle disorders. Then we have sensory loss. Sensory loss. Sensory loss can be there or may not be there, but in human, there will be prominent cortical sensory loss. Prominent cortical sensation loss will be there, which means the cortical sensations will be the ones that will be prominently lost rather than any other things. But even the things can be variable. But like sensory loss can be there. We are talking about an associated sensory loss. We are not talking about, because you might ask, like, sir, you told UMN, it's a motor neuron. Then how can you talk about sensory loss here? We're talking about associated sensory loss. Can be there, but prominent cortical sensory loss only will be there. And here again can be there or not depending on what type of neuropathy it is. It is quite variable. But see here, this is not important thing. The most important thing to understand is myopathy and neuromuscular junction disorders will not have any form of sensory loss. That's what the most important point here is. They will never have sensory loss. Human element may or may not have sensory loss, but the presence of sensory loss rules out a neuromuscular junction disorder and myopathy. A pure myopathy cannot have a sensory loss. Then what about bladder and bowel involvement? Bladder and bowel involvement, variable here, here also variable. It can be there or cannot be there. But typically bladder and bowel involvement will never be there in the setting of a pure myopathy. We are talking about a muscle problem, skeletal muscle problem, not about a smooth muscle problem. Similarly, if you talk about neuromuscular junction disorder in a presynaptic disease, it may be there. In a postsynaptic disease, it will not be there. For example, the best example of a postsynaptic disease is myasthenia gravis. The best example of a presynaptic disease is Lambert-Eaton myasthenic syndrome and botulism. In botulism, bladder bowel involvement can be there. Lambert-Eaton myasthenic syndrome, botulism bladder bowel involvement can be there. But in postsynaptic disorders like myasthenia gravis, bladder bowel involvement will not be there. So that's why I told you it is variable. Similarly, in LMN also, it is quite variable depending on the type of disease. So these are the basic ways to differentiate between a human, LMN, neuromuscular junction disorders, and myopathies to start with. And we have not discussed about the spinal muscular atrophy. There are some important botulism and LEMS. LEMS, haven't you heard of LEMS? That is Lambert-Eaton myasthenic syndrome. I think you would have heard about that, right? Lambert-Eaton myasthenic syndrome. Definitely yes. That's a paraneoplastic syndrome. Okay. So then let me talk about some kind of spinal muscular atrophy. If time permits, please explain autonomous. If time permits, I will tell you. So spinal muscular atrophy, SMA is a pure element disorder, first of all. And only the types of SMA are important. For example, we have 4 different types of SMA. One is called SMA type 1. There is a special name that is given to SMA type 1 that is called as Wernicke-Hoffmann disease. Wernicke-Hoffmann disease. Wernicke-Hoffmann disease. Wernicke-Hoffmann disease typically presents in infants, and usual onset will be at birth. At birth itself, they can be diagnosed, and typically diagnosed with something called a floppy baby syndrome. So one of the important differential diagnosis of floppy baby is Wernicke-Hoffmann, and usually they die within 2 years, most often. So they will not survive. So this is a very tough disease to treat and cannot be treated as well. There's a neurodegenerative disorder. And most often these babies will appear a type of posture called as a frog posture. Frog, like frog, the frog that we see, frog posture at resting state. So these are the clues to tell in exam that it is a Wernicke-Hoffmann disease, SMA type 1. Then we have an SMA type 2, which is referred to as something called a Dubowitz disease, SMA type 2. So usually it will not present at birth, definitely not present at birth, but it will start somewhere in between. So within 18 months, they will start getting the disease, somewhere within 18 months, but definitely not present at birth. So it's not a condition that produces floppy baby at the time of birth. These children can sit, but can't walk. Can sit, but can't walk. And they will develop serious contractures over the period of time. So this is Dubowitz. As far as SMA type 3 is concerned, this is called as Kugelberg-Wiellander disease. Kugelberg-Wiellander. Dubowitz, then we have Kugelberg-Wiellander disease. Usual typical onset is around 5 to 15 years, which means a little older child, 5 to 15 years. They can sit, they can walk, but walking will be abnormal with a waddling gait. That is because of the muscle weakness. Waddling kind of a gait will be there. Usually around 30s, they'll go for wheelchair. They'll be completely wheelchair bound. And after that, they will die around 30s and 40s. So that is Kugelberg-Wiellander. Riju is asking who gave these names. Actually, Wiellander is a very big neurologist, man. Wheelander test is there. Tomorrow I'll ask you what is Wheelander test. There's something called a Wheelander test, which is used to identify fasciculations in amyotrophic lateral sclerosis patients. Wheelander test. Okay. I mean, if I tell the eponyms alone in neurology, you will go more mad. I can talk about only the eponyms for 3 days. What are the named signs are there in neurology? There are almost like 1,300 names are there in neurology. You all be knowing only one Babinski. But I can tell total of 11 Babinskis totally. There are totally 11 Babinskis from head to toe. So usually in my postgraduate exam, my professor asked, what are the 11 Babinskis? Tell from head to toe. Where all Babinski is there? We all know Babinski in the plantar, but we don't know where are the Babinskis from head to toe. 11 Babinskis are there basically. It's not that easy. So many named signs are there. So that is why, as far as neurology is concerned, if the examiner decides to kill you, he can easily kill you. He can ask something from some textbook, and if he asks, you cannot answer surely. It's easy to ask questions, but difficult to answer anyways. That's always true when it comes to neurology. At least cardiology, you can match up something and you can tell. Neurology is very difficult because most of them are names, most of them are pattern based, and the same pattern can be present in multiple diseases. You can't really predict. So what is the disease that the patient is having, but we can only give the differential diagnosis. That is why when you have a neurological discussion in exams, you always go with the differential diagnosis approach. If you tell concretely that this is the diagnosis, you will surely fail. Even at a UG level, never give a concrete diagnosis. I mean, in neurology alone, that's very, very important. You always have to give a differential diagnosis for your safety. And that differential diagnosis that you give should be extremely sensible. In the sense like it should not have a complete mismatch between one disease and another disease you give because one factor is coinciding. You get that 2 diseases are same. No, not like that. There should be some at least good overlap between syndromes, and you have to give that as a particular differential diagnosis. So, I mean, UG level, I think the exams have become a joke now. I'm seeing my hospital, right? I've been conducting a lot of exams. UG level, the exams are a full absolute joke. There is nothing you're going to fail in a UG level. If you fail in a UG level, it means that you have done a terrific blunder. For example, one of my students, out of fear, she told, what is the treatment that you'll use in varicose bleeding? I don't know what she thought. She answered heparin as the answer. She's a brilliant student. She's a good girl. She's not like very bad and all. But she answered heparin for varicose bleeding. And examiner got shocked. He's seeing like this. Heparin for varicose bleeding. I don't know what she really thought. See, I can argue basically. For example, in portal vein thrombosis, I can give heparin. That can also cause portal hypertension. So, see, medicine, you can argue anything, but you should not argue like that. So, in a varicose bleed means the examiner thinks about a cirrhosis case and you tell a heparin in cirrhosis for varicose bleed, she's a good student. It's not like she's a very bad student either. She scored a good mark in the mock tests and all. She's really a good student only. But I don't know why she told suddenly like that, maybe out of tension or something, but she was failed. So this is the usual reason why you fail in UG. I don't think if you don't tell the 11 Babinskis, you're going to fail. And even if you tell, sometimes being too smart in undergrad exam is also very bad. Even postgrad exams itself is very bad. You should never be too smart. When you go to exams, answer only what is relevant. And if they ask something, your words should come out of your mouth like a gold. There should be only few words you should speak, and that should make a lot of sense. You should not keep on blabbering something, or if you should not keep on telling DDs after DDs, that is also very dangerous because they might pick up one of the DD and they go into that particular DD, and that will be a problem again. So you should not do that as well. Clear. So, I mean, there is a separate, thing how to, I used to, when I was a assistant professor, I used to tell my kids, whenever UG kids come, I tell all these things before the exam, how to behave inside the exam hall. That's the most important thing, and what to talk and what not to talk. That's the most important thing. And if that you do properly, even if you don't answer it, that's fine. So you will pass. Yeah, I mean, that's why I'm telling you, if you have failed, that doesn't mean that you're a very bad student. And I believe that, that's not a big deal. It's up to you how you take. I don't really believe that failure makes me a very bad candidate. No, it's not a thing. You have to appreciate failure and success as an equal entity, according to me. There's nothing like if you are failed, it means you are doomed for your entire life. Yes, Sankhya is telling UG become just an entrance to post-graduation. Yes, of course, yes. That's why I'm telling that from the beginning to many people, I'm suggesting that you can make UG as a probably, like a correspondence course, isn't it? You can sit in the home, you can listen to me because I'm going to take in online, and many other teachers are also going to take in online. So why you want to go to unnecessarily, you have all 3D models in the home itself with anatomy and all. Why you want to unnecessarily go to hospital and save a lot and waste a lot of government's resources as well as your resources and your energy, time. Sit in home, write only exams at the end of year. That's what anyway students are doing now. Anyway, they're not planning or willing to go to hospital by any means, and COVID has made the scenario even more worse. So I think you can make the undergrad exam as a correspondence course and directly grant the license to kill patients. Or if you don't want to kill patients, then come and practice as a postgraduate. And now even postgraduates has become very worse, because postgraduates are also seeing that MD or MS as a like pathway towards the super specialty. And once they do go for super specialty, they keep crying that I didn't do my basics properly. That's why I'm not able to do well properly in the post-graduation. So it's all like that. During a UG and a PG, they don't want to study. When they go to post-graduation, they feel very sad that I didn't do very well in the UG and PG itself. So it's like a cycle. So to avoid that, be careful. You don't end up in the same sitting. The future is going to be very bad. Competition is going to be extremely worse. And if you want to survive in that competition, you should be something different. Of course, otherwise it's very difficult to survive. And everyone is competing very hard. And there's so much of people who are going to come in the next 10, 20 years. Be careful. And then we have a SMA type 4, that is spinal muscular atrophy type 4. It's an adult onset SMA. As the name tells, adult onset SMA, the onset will be approximately by around 30 years. And these patients will be having significant proximal weakness. But one important point is that these patients will have a normal life expectancy. That's most important point. Among all the spinal muscular atrophy, the only spinal muscular atrophy which has a normal life expectancy is SMA type 4, that is a adult onset SMA. But this patient will have a significant proximal weakness. Significant proximal weakness. Still, they will be disabled a lot, but they will have a normal life expectancy overall. Among all the SMAs, this is the only thing that is normal life expectancy. The one with the worst life expectancy is SMA type 1, that is Werdnig-Hoffmann disease. Very common question in exam, Werdnig-Hoffmann. They have asked in pediatrics 2-3 times. Floppy baby, like who's adopting a frog posture. If they give this kind of words, it directly points to Werdnig-Hoffmann. The baby will usually die within 2 years. You cannot do anything. And you have another disease, which I promised to tell. That's called a Kennedy disease. So this has been asked once in the exam in 2012 AIMS. That's called the X-linked bulbospinal atrophy. X-linked bulbospinal atrophy. This is also basically a trinucleated repeat disorder only. If you want to know the name, I'll repeat again. X-linked bulbospinal atrophy, BSA. X-linked bulbospinal atrophy. Basically, this is also a trinucleated repeat disorder. And it is a CAG repeat. I'll come back to that. What do you mean by a CAG repeat? First of all, you need to know what do you mean by trinucleated repeat disorder. I'll tell you a short way about what do you mean by TNR, triangle repeat disorder. Triangle repeat disorders, the inheritance can be variable. Like it can be autosomal dominant, it can be autosomal recessive, it can be X-linked disorders. So inheritance can be different. So many students think that triangle repeat disorder, they confuse with this sort of inheritance. Inheritance is different. The Mendelian pattern of inheritance can be anything. It could be autosomal dominant recessive or X-linked, doesn't matter. But in triangular repeat disorder, there will be triplets of nucleotides that will be repeating multiple times. So based on the triplet repeats, it's divided into either a CAG repeat disorders or a non-CAG repeat disorders. CAG usually codes for glutamine. Glutamine is called as Q. That's why these disorders are also called as poly-Q disorders, are also referred to as polyglutamine disorders. Glutamine is actually denoted by letter Q in the amino acid dictionary. So that's why it's called a poly-Q disorder, polyglutamine disorder. It's a CAG, trinucleated repeat disorder. There are a group of disorders that come under the CAG, poly-Q repeat disorders. Of course, the first example you always tell is the Huntington's disease. It's a form of dementia. Huntington's disease or Huntington's chorea. That's one of the first diseases that should come into your mind whenever you talk about a CAG repeat disorder. That's a polyglutamine or poly-Q repeat disorder. Then next thing that should come is majority of the types of spinocerebellar ataxia, except few types like 3 and 7. Majority of the types of spinocerebellar ataxia will be coming under CAG repeat disorders only. Then we have the Kennedy disease, that is X-linked bulbospinal atrophy. This is also a CAG repeat disorders only. And similarly, When you talk about non-CAG repeat disorder, there are 3 disorders that are very commonly asked in exams. One is going to be the CTG repeat. CTG repeat is characteristically seen in a myotonic dystrophy. Myotonic dystrophy, otherwise referred to as dystrophica myotonica, which we'll be discussing subsequently, especially the type 1 myotonic dystrophy, which is very common question exam. Then we have a GAA repeat disorder, which typically seen in Friedreich ataxia. We discussed some time back. I told how to diagnose a Friedreich ataxia in exam and in your common practice. Then you have a CGG repeat. CGG is typically a Fragile X syndrome. Fragile X. So these are the 3 disorders that you'll be getting in exams: CTG, CAG, CTG, GA, and CG repeat disorder. Remember, rest of all are basically CAG repeat disorders only, poly-Q repeat disorders. And you know, number of repeats is a common rule, is directly proportional to the severity of the disease, which means more the number of disease, more is going to be the severity. And there is one more phenomenon that is present in these guys are called as genetic anticipation. Genetic anticipation. SCA means spinocerebellar ataxia. I told you, one of the types of spinocerebellar ataxia that is common in India is Makeda-Joseph disease, which is a differential diagnosis of a amyotrophic lateral sclerosis, which I have discussed some time back. I think you remember that. That Makeda-Joseph disease is a type of SCA, that is spinocerebellar ataxia. You have multiple different types. So most of them will be coming under CAG repeat disorders only. And everyone knows what you mean by genetic anticipation. So at every generation, more repeats, early disease with more severity. So that is genetic anticipation. So basically it's a trinucleotide repeat disorders only. Usual age of onset will be approximately middle-aged. I mean, around young adults, like around 30 years, that's where they will start with. And usually males are affected more than females. If males are affected, there will be some characteristic findings that will be seen in these guys. It's very characteristic. That's why this is a very common exam question. Usually they'll go for testicular atrophy. And because of testicular atrophy, 2 things will happen. One is gynecomastia. These patients will have gynecomastia. And these patients will have infertility. Infertility as well. And they can have diabetes. They can have diabetes and they can have muscle cramping. They come with muscle cramps. Most of the time these muscle cramps are nothing but fasciculations, as I told you, because this is an anterior cell damage. We have studied this, and this is a pure element disease. And at the same time, they'll be having atrophy, weakness, of course, and they'll be having bulbar involvement. Bulbar involvement means most often, prominently, they'll be having dysphagia. If you see all these things, what disease you think it's going to be the most important DD here? Just by a look. If you're good in neurology, you should be immediately able to tell one disease that is going to mimic this. And it's a trinucleotide repeat disorder as well. What disease can mimic this kind of picture? To tell an overall vague differential diagnosis. Because if you tell something, I can tell why it is not that disease. If you tell something, I can tell why it is not that disease. That's why it's that kind of discussion is what we need, because we need differential diagnosis. With these features, you might be mugging up right now, all these features during exam. But how will you differentiate in exam if there are 4 options or in reality? So many people are giving Friedreich ataxia as an answer. Okay. Friedreich ataxia happens in around 15 years, less than 15 years. So age is a problem here. Okay. So Friedreich ataxia means it will be less than 15 years. Fine. So cardiomyopathy is very rare in, like your X-linked bulbospinal atrophy. Kennedy's cardiomyopathy will not be there. Then what else? Here, the most important thing, there is no postal imbalance. Ataxia is not a feature here. You don't have ataxia. Then how can you tell it is a Friedreich ataxia? No ataxia. Age of presentation 30, less than 15 Friedreich ataxia. And the patient is not having cardiomyopathy. So as far as your Friedreich ataxia is concerned, they will not have dysphagia. Dysphagia is a very important thing. That they don't have dysphagia. And Friedreich ataxia, typically they won't show this cramps and atrophy and all, because there is no anterior cell damage. So it's totally going against Friedreich ataxia. It's not the case. Then what else? Adult Tay-Sachs. So where is the hepatosplenomegaly here? Adult Tay-Sachs. And Tay-Sachs will have other multiple organ involvement. That is not there here. So it's not Tay-Sachs. And somebody is telling myasthenia straight away, outright, that's a very bad diagnosis because atrophy is never a feature of myasthenia gravis. And this fasciculations, 100% you will not see in myasthenia. 100% not sure. And diabetes goes against myasthenia again. Why should the patient should have diabetes? And that's not the case. And I expected somebody to tell myotonic dystrophy. That's what I was expecting. Somebody to tell myotonic dystrophy, because myotonic dystrophy has some kind of characteristic features that can be mimicking Kennedy disease. For example, myotonic dystrophy patients can be having distal weakness predominantly. Distal weakness, but they can have diabetes, they will have cardiomyopathy, they will have the characteristic myotonic phases, which I'll be discussing sometime, like that kind of, like that innocent face because of bilateral facial palsy, frontal balding, and these patients will be having gynecomastia as well. And these patients will be having testicular atrophy. And these patients may also have one more thing. What is that? Dysphagia. Dysphagia is common in these disorders as well. So that's what I expected basically, because this also comes around 30s, 40s. So what are the common things? Age, diabetes, gynecomastia, testicular atrophy, dysphagia. So many common things are there. But what is the thing that goes against myotonic dystrophy? Myotonic dystrophy is basically a muscle disorder. So cramping and fasciculation should not be the key here. Cardiac involvement can or cannot be there, but it's not very prominent in the setting of your Kennedy's disease, but it is very prominent in other disorders. So, but usually in exam, they won't give cardiac involvement prominently. If you see cardiac involvement in Kennedy's, if you ask yes or no, yes, 5 to 15% cardiac involvement may be there, but I don't think that is important for exams. Don't differentiate based on that cardiomyopathy. Then what is the thing that separates myotonic dystrophy then? So myotonic dystrophy will have something called a myotonia. Myotonic dystrophy will have something called a myotonia. If you have myotonia, I mean, this is not a feature definitely of Kennedy's disease. So myotonia is not there. At the same time, your atrophy and weakness is never a feature of myotonic dystrophy because it's a muscle disorder. Sometime back only we studied, where is that? In muscle disorders. Yes, in muscle disorders, we don't see atrophy, surely. We don't see fasciculations, and we don't see this kind of problems. So definitely, yes. So definitely this is not myotonic dystrophy. So remember, I told just an example. Why I want to discuss this is how you think about a differential diagnosis. Whenever you think about some characteristic features, rather than just mugging about that particular characteristic feature, just ask yourself a question: why not this particular disease? Why not that particular disease? And what are the differential diagnoses, and how can you differentiate each and every disorder? So in Kennedy disease, this is the exact same finding that you'll get in exam, but you should not confuse with other disorders. So when you think about differential diagnosis, when you take the options and see why not this disease is mimicking this pattern that is given in the exam probably. So this is Kennedy disease. This is going to be what is that? Kennedy disease. And more often Kennedy disease patients will have family history. That's also very important. And this can be very useful clue whenever it comes to other diseases in exams. Many of the other MNDs we talked about will not have family history properly, but this will have a strong family history, which is very, very important. And more often, this muscle cramps, atrophy, weakness, and fasciculations will be more often in the spinal muscles compared to the limb muscles. This is another differential diagnosis. So the spinal involvement will be very severe in the setting of a Kennedy's disease compared to the limb involvement. Whereas your myotonic dystrophy will have more of a limb involvement, not the spinal involvement. Spinal muscles will be the most severely affected in case of Kennedy disease. That's why it's called a X-linked bulbospinal atrophy, where they have bulbar weakness with spinal muscle problem. That's why it's called a bulbospinal atrophy. Along with that, you will have other features like whatever I said. I think you must be able to get that. So the next disorder which we need to discuss is on the acute transverse myelitis, ATM. So we have acute transverse myelitis, ATM. So remember, acute transverse myelitis is pathologically a non-compressive lesion. It's not a compressive lesion, which means it's an inflammatory condition. Basically, there is no compressive lesion that is happening, but basically it behaves like a compressive lesion. So which means it's going to mimic a compressive myelopathy. Clear? It's going to mimic a compressive myelopathy. Whenever you talk about a compressive myelopathy, which is going to, it's going to mimic compressive myelopathy, means it's going to affect the entire particular level of the spinal cord will be like completely compressed. So that's how it's going to, that's how it's going to present. You can also imagine like myelitis means, acute transverse myelitis means, it's an inflammation. Because of severe inflammatory exudate in that particular area, you might result in development of a compressive symptom sort of a thing. You can remember like that also. But anyways, nevertheless, it's going to mimic a compressive myelopathy. So, number one, most importantly, whenever you talk about a compressive myelopathy, you are going to tell one first thing is sensory level. That's the most important thing. So in exam, this is very important. So if they ask you why not it is acute transverse myelitis, if you get a DD, for example, you are getting a case of paraplegia, or probably you are getting a case of limb weakness, bilateral limb weakness, they'll ask you, first question, if you thinking about something else, they'll ask you, why can't it be a spinal cord lesion or why can't it be a acute transverse myelitis? So first thing you have to utter from your mouth is, because I don't have a sensory level, it cannot be a compressive spinal cord lesion. Because there is no level. Sensory level should be there. Pakka, like the patient will tell, below this, I'm not having sensation. Above this, I'm having sensation. For example, if it's a T4 spinal cord involvement, the patient will tell exactly, you can demonstrate that at the level of the nipples. Below that, the patient will not have sensation. Above that, the patient will have sensation. So that will be pakka sensory level will be there. So that is very characteristic of a compressive spinal cord lesion. Basically, it's a non-compressive myelopathy, but it behaves like a compressive myelopathy. That's what I'm trying to tell. If you take the textbook and see, they would, why I'm telling this many times is because when you're going to go to the textbook and come back to me again, so should not come back. So remember, it is basically a non-compressive myelopathy. There is no mass lesion here, but it's going to behave like a compressive myelopathy only, which means they're going to come with a sensory level. That's the most important. But if you take that classification in the textbook and see, acute transverse myelitis will be given in the non-compressive myelopathy only. But it will have a sensory level because it's going to behave like a compressive myelopathy. So what are going to be the etiology? There are few etiologies that you need to know for exams. The first etiology and the most common etiology is idiopathic. We think it's due to some viral infection, but we don't know what is the exact etiology. Most of the time it will be idiopathic. It can happen after a known viral infection. For example, Epstein-Barr virus infection, or it could be after a bacterial infection, post-bacterial infection, like for example, a mycoplasma, very commonly asked in exam, EBV and mycoplasma. After that, you can get an acute transverse myelitis. Then post-vaccination. And this should be very familiar because I think 3 weeks back, Russian vaccine, which was known to enter phase 4, was deferred because almost 2% of those who received vaccine developed acute transverse myelitis. So you can imagine with COVID itself. So many vaccines can cause acute transverse myelitis, and that's why we have 5 different phases of generating a vaccine. And that Russian vaccine was actually deferred from further use because 2% of those who used developed acute transverse myelitis within 2 to 3 weeks of the illness. So that's what I'm trying to tell. Within 3 weeks of vaccine, generally, it is possible to get an acute transverse myelitis. And you can get in demyelinating disorders. Demyelinating disorders. 2 demyelinating disorders are extremely important. One is your multiple sclerosis. Of course, it affects the spinal cord. Second is the neuromyelitis optica. That is otherwise referred to as a DWIX disease. So these are the 2 important demyelinating disorders of the spinal cord. So these are the most important etiologies and differential diagnosis as far as the acute transverse myelitis is concerned. Then what about the clinical features of acute transverse myelitis? The most important thing to find out is whether it is an acute transverse myelitis or a subacute transverse myelitis, because that will give a little bit of clue. Most of the times, acute transverse myelitis will be usually due to neuromyelitis optica, very acute. A subacute will be some other things. Other entities which I have discussed will be usually subacute in nature only. They will not be very acute, including multiple sclerosis. Then next thing is to differentiate whether it's a partial transverse myelitis or a complete transverse myelitis. So when you call it as a partial transverse myelitis, when you call it as a complete transverse myelitis. Partial means usually it will involve less than 3 vertebral segments. It will not involve more than 3 vertebral segments. The Next thing is like they will be more asymmetric in nature. I mean, remember that asymmetry is also a feature of a compressive myelopathy. We studied some time back. So in a compressive extramedullary lesion, where is that? That asymmetricity is a very important thing. So that is why I told you acute transverse myelitis is one thing that is a non-compressive myelopathy, but has a lot of compressive features. So they'll be more asymmetric in nature, and they'll be predominantly peripheral in location. Like a compressive myelopathy, they come from the side, more peripheral. They'll affect only limited tracts. Again, like a compressive lesion, they'll affect only limited tracts, which means they will involve mostly the pyramidal tract and the posterior column. Sometimes the spinothalamic tract may be spared. Usually, very commonly, they'll involve the posterior column and the corticospinal tract. Spinothalamic tract may be spared, and they can have a dissociative kind of a sensory loss also. Whereas complete transverse myelitis, you will have more than or equal to 3 vertebral segments involved. So whenever these kind of 3 and above vertebral segments are involved, that is also referred to something called a LETM. So what is LETM? That is called a longitudinal extensive transverse myelitis. LETM. LETM means longitudinal extensive transverse myelitis, complete transverse myelitis. More often it will be more symmetric in nature, and it will behave more like a central cord syndrome. It will be central, and they'll have a reduced motor, sensory, and sphincter function. And the most important example, classical example of this kind of complete transverse myelitis in exam, of course, is neuromyelitis optica. Nothing else can be a differential diagnosis in exam. Neuromyelitis optica. Neuromyelitis optica is one disorder that is highly known to produce this kind of LETM, longitudinal extensive transverse myelitis. Whenever they give the word complete transverse myelitis, LETM, then you are going to answer neuromyelitis optica in your exams as a standard differential diagnosis and standard answer. So the best example, if they ask you about partial transverse myelitis, is multiple sclerosis. Remember, transverse myelitis in MS is always partial. It's never complete. Clear? It's always partial. It is never going to be complete. Fine. So treatment of acute transverse myelitis, you're going to give only steroids most of the time. So it works or it may not work, it depends, but we can use steroids depending on, again, depending on the cause you can treat. For example, in NMO, I'll urgently give intravenous immunoglobulin, but whereas in multiple sclerosis, it depends again. So depending on the cause, you can try different treatments, but most often if they simply ask, what is the treatment of choice for acute transverse myelitis as far as exams are concerned, you can go for steroids as a very important treatment in this setting. Then there are 3 differential diagnoses that you need to differentiate in exams, clinically, as well as what will be the MRI findings and what will be the CSF findings. Based on that, you have to differentiate in exam. The first one is going to be the multiple sclerosis. In multiple sclerosis, remember, it will be typically asymmetric, as I told you. It will be a partial transverse myelitis only. The lesion distribution also will be more asymmetric when you compare clinically, and MRI will more often involve less than or equal to 2 vertebral segments only, which means it will be partial, less than or equal to 2 vertebral segments, and more often you will have a brainstem lesions in MRI, which is very classical, and you will have an enhancing lesion as well. This will be enhancing with contrast. This is characteristic MRI finding. As far as the CT is CSF is concerned, they will have OCBs. More than 90% of the MS patients will have oligoclonal bands, and there will be something called a increased IgG in the CSF. That's called an IgG index. 60% incidence of this increased IgG index. So that's a very common entity again. Then second entity that we need to discuss is NMO, that is neuromyelitis optica. Usually the findings in neuromyelitis optica will be more symmetric in nature, as it's mimicking a central cord syndrome. And most often they'll be having associated optic neuritis, which we'll be discussing subsequently. As far as the MRI is concerned, usually the involvement will be long, more than or equal to 3 vertebral segments, as I told you, and they may also be enhancing. But this long involvement, longitudinal extensive transverse myelitis in exam, is basically the go for neuromyelitis optica. And as far as CSF is concerned, you will not have any oligoclonal bands. OCBs will be negative, and IgG index will be basically normal, no elevation of IgGs as far as NMO is concerned. And number 3, you have another disease called ADAM that is going to closely mimic MS and NMO, that is called acute disseminated encephalomyelitis. Very common in exam. I'll tell you how to differentiate. Usually, ADAM is basically a monophasic illness, which means it happens only once. And ADAM is very common in children. If they give children who are suffering from this kind of sudden onset paralysis, especially if there is a history of infection, prior infection, and especially post-vaccination, extremely common. Post-vaccination, and most often this ADAM will have cerebellar involvement. That is very important. They will present with encephalopathy. They will have weakness because of spinal cord involvement, and at the same time they will be having cerebellar symptoms. This is the differentiating clue. Cerebellar symptoms. They will present with ataxia. So in exam, this is a very favorite question. Post-vaccination, child coming with encephalopathy, weakness, and ataxia. Think about acute disseminated encephalomyelitis. Very common in children, not in adults. Typically, there will be non-enhancing lesions. That's why this point is very important. They will have white matter lesions, but they will be non-enhancing in nature. They will not enhance with contrast. But whereas your MS and NMO lesions are basically enhancing in nature, whereas ADAM lesions will be basically non-enhancing. And these are also demelting disorders only. So there is no difference in telling it is non-demelting or demelting. All are demelting disorders. And involvement wise, it is variable. They can have a long involvement or they can have a short involvement. So involvement wise is variable. Involvement wise, you cannot tell whether it is ADAM or NM or MS just by the basis of how many vertebral segments are involved. CSF findings are highly variable. You cannot tell anything with respect to CSF findings. But the most important clue in exams is going to be the non-enhancing lesions in MRI. At the same time, this characteristic presentation of a child after an infection or after a vaccination coming with encephalopathy, weakness, and cerebellar symptoms. So that's why it's called as acute disseminating encephalomyelitis. That's why they have encephalitis, they have myelopathy in the form of weakness, and at the same time, it's a white matter problem only. So ADAM is there. We'll be discussing more about ADAM in some time. So these are the 3 important differential diagnoses that you have to make in exam. So I've highly compressed the information into whatever you need for exams, because there are so many differential diagnoses, so many disorders are there in this, and so many variants are there. So if you're going to study Harrison, you're going to really get pissed off. But this is how the examiner asked the question. That's why I want to tell only this. So with this, we are going to another big area, huge area, that is called multiple sclerosis. We need to discuss, because MS is something that is going to affect the brain as well as the spinal cord. So we need to know about multiple sclerosis. It's a very important demelting disease. So if they ask you the most common demelting disease of the central nervous system, demelting disease of central nervous system, answer is multiple sclerosis. Most common demelting disease of the peripheral nervous system, answer is Guillain-Barré syndrome. We know that. But the most common demelting disease of the central nervous system is basically multiple sclerosis only. Remember, multiple sclerosis is very common in females. We know that. It can happen in any age, but commonly in the middle age group, it's common. At the same time, it's very common in temperate climates, which means in cold climates, it's very common. That's why they told the possibility of vitamin D deficiency as a cause. But if that is the cause, then every of us should get multiple sclerosis. And I don't think that's a very important cause. Some genetics are there in those living in temperate climates. So that is why they're getting MS very commonly in the cold climates. In India, it's not a very common disease. And we know it's an autoimmune disease. And typically, there is 2 types of hypersensitivity going on. One is type 2 and type 4 hypersensitivity reaction that is going on in MS. But if you want to know single most important hypersensitivity reaction that happens in multiple sclerosis, that is type 4 hypersensitivity. That's going to be the most important as far as MS is concerned, because it's a T-cell mediated immunity only. And as I tell you, it's a demelting disease. Tell me which will have myelin. You have white matter, you will have myelin, or gray matter, you will have myelin. So which will have myelin basically? I mean, this is a very basic, huge level question, first year level question. Which will have myelin? White matter or gray matter? So white matter is the one that's going to have myelin. Of course, yes. So which means multiple sclerosis is a white matter disease. Number 1. It's a white matter disease. It is not a gray matter disease. It does not affect the gray matter. If it's not going to affect gray matter, then there are certain things that becomes extremely rare. For example, dementia is very rare in MS because it does not affect the gray matter. Your cortical symptoms and signs are very rare in MS. You don't get cortical symptoms and signs because white matter is subcortical, gray matter is cortex. So you don't get cortical symptoms and signs. Aphasia, apraxia, very, very rare. Late stages you might get because of neurodegeneration, but apart from that, it's extremely rare. Seizures are very, very rare in MS. You don't get seizures very commonly in MS. The reason is because it doesn't affect the gray matter. That's the main reason. And second important point to notice, it's a white matter disease of the central nervous system. I'm telling again and again, which means what are the constituents of central nervous system? You have brain and the spinal cord, which means it does not affect the peripheral nervous system. It has nothing to do with the PNS. It is not going to affect the peripheral nervous system, which means there is another thing that you may not be seeing in MS is peripheral neuropathy. So these are exclusion points in exam. If there is peripheral neuropathy, it's not MS. It cannot produce peripheral neuropathy because this disease is confined within the central nervous system. Because they're basically going to affect the oligodendrocytes. This is where the problem is predominantly, and they're not going to affect the Schwann cells, which are going to myelinate the peripheral nervous system. So one more interesting point is there here. If it's not going to affect the PNS, if it's not going to have peripheral neuropathy, and if it's going to affect the CNS, cranial nerve involvement will be there in MS, or cranial nerve involvement will not be there in MS. I'm talking about an element cranial nerve involvement. Element cranial nerve involvement will be there in MS or will not be there in MS because it's an exclusive CNS disease. So cranial nerve involvement will be there or will not be there. Answer is cranial nerve involvement is not possible in MS. Usually you don't get cranial nerve involvement in MS because if you take a peripheral nerve and if you take a cranial nerve, both are the same. Peripheral nerve are originating from anterior horn cells. Cranial nerve originating from cranial nerve nucleus. But for both these things, you need a UMN. This UMN is corticobulbar tract. This UMN is corticospinal tract. But nevertheless, both are going to originate from the bed cells only. Bed cells of the brain only. Which means cranial nerves are also LMN only. Peripheral nerves are also LMN only. So MS is a disease of upper motor neurons. It will not affect the lower motor neurons at all because it cannot cause peripheral neuropathy. So cranial neuropathy, LMN cranial palsy is impossible in the setting of a multiple sclerosis. Absolutely impossible. You cannot get LMN cranial palsy. So that is why it is not going to touch the LMN cranial nerves. Similarly, if you want to know about one disease, that is a demyelinating disease of the peripheral nervous system. What is that disease? What is the demyelinating disease of the peripheral nervous system? Obviously, in exam, you are going to get only limited questions in neurology. You're not going to get pissed off. Very simple. The most common demyelinating disorder of the peripheral nervous system is Guillain-Barré syndrome. And remember, Guillain-Barré syndrome will very commonly affect cranial nerves, which means LMN seventh nerve palsy. I have told most common cause of bilateral seventh nerve palsy in exams, if they ask, is Guillain-Barré syndrome only. Very, very common disease, which can affect the LMN cranial nerves. But MS never causes LMN cranial palsy. But it can affect the UMN. I'm not telling no. UMN can be affected to a large extent, but it's not going to affect the LMN for sure. At any cost, it's not going to affect the LMN. Okay. Then, but usual confusion starts in one area. You would have studied in MS, optic neuritis is extremely common. In GBS, if there is one thing that will not happen, optic neuritis will not happen. This is what you would have studied. So now it's confusing. So why, like cranial nerve involvement, we told it's not there in MS, where in GBS very commonly they'll produce cranial nerves. But why the hell MS should produce optic neuritis and GBS should not produce optic neuritis? Because optic neuritis is not a true peripheral nerve. Optic neuritis is a direct extension of the brain itself. We know that. Because optic neuritis has a lot of, in fact, all factor nucleus also, even cranial nerve 1 also has the same kind of orientation. That's why yesterday's brainstem, when we started the approach, I told you 1, 2, you leave because that's not a true cranial nerve. Only 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 are true cranial nerves. That's coming from the brainstem. 1, 2 is not even in the brainstem, but it's our mistake to keep 1 and 2 within the cranial nerves. We should not have done that because they are actually direct extensions of the brain. For example, take the optic nerve. They originate from the diencephalon, which means it's a brainstem structure. Then, as far as the myelination is concerned, myelination of optic nerves is basically done by oligodendrocytes only, not by Schwann cells. But rest of the cranial nerves are actually myelinated by Schwann cells only. And the third differentiating point is optic nerves have meningeal covering. That's why you're able to look at papilledema in the setting of raised ICP. So a lot of things, lot of evidences are there that optic nerve and olfactory nerve are basically not a cranial nerve. They are not true cranial nerves. They are basically extensions of the brain itself. And since optic nerve is also myelinated by oligodendrocytes, basically they are human only. But we are mistaking that optic nerve for element. So that is why the disease does not mistake. Disease still affects the optic nerve. If there is one nerve that GBS cannot affect, it is the optic nerve. So optic neuritis is not possible in GBS, which means if they ask you all of the following cranial nerves are involved in Guillain-Barré syndrome, except your answer is going to be optic nerve or probably even olfactory nerve. Will not be affected in the setting of Guillain-Barré syndrome because it's a true peripheral neuropathy. Clear? But MS, optic neuritis, is extremely common. 20% of the patients with MS will have some form of optic neuritis. So it is extremely common. So that is one point that you need to know. So optic nerve is not a true cranial nerve. So you leave all the cranial nerves separately, 1 and 2 separate. Even though we put them under cranial nerves, but it's our confusion, human confusion. Basically, disease does not confuse. 3 to 10, 3 to 12 are different. 1 and 2 is different. So optic neuritis still can happen in MS, but element cranial neuropathy will not happen. So Vikram is asking, can human type of involvement of 7th can be involved? Yes, of course, it can be involved in MS, human type of 7th nerve palsy. I told you already. That's why if you understand, I think the previous one I deleted, I think. If you go to the previous discussion, and of course, if we think about the previous discussion, I have discussed about the bulbar versus pseudobulbar palsy. In that, in lower motor neuron type, I have discussed about GBS, whereas upper motor neuron type of palsy, I have discussed about MS, which means the lower motor neuron type of palsy is not possible in multiple sclerosis. Only the upper motor neuron type of paralysis will be possible in multiple sclerosis. That's why, remember, no peripheral neuropathy, no element cranial palsy. Can't the cranial nucleus in brainstem be affected in multiple sclerosis? No, cranial nucleus in brainstem can't be affected in MS. It doesn't affect the cranial nucleus. It affects only the human. So that is why it causes only pseudobulbar palsy. It could have caused bulbar palsy, right? Otherwise, then why it causes only pseudobulbar palsy? Usually, it will not involve cranial nucleus. So no peripheral neuropathy, no element cranial palsy. But optic neuritis is extremely common because it's something different. It's a disease of white matter of the central nervous system. It doesn't have any cortical symptoms and signs. These symptoms are extremely rare. So just by knowing that one word, that it is a demyelinating disorder of the central nervous system and it affects the white matter. Just with using these 3 words, you can extrapolate everything and find out what are things that will happen and what are things that will not happen. So it doesn't need a big knowledge or to study something extraordinary. So all these things are going to be very simple in multiple sclerosis. And as far as pathophysiology, I'll discuss later on when I'm going to discuss about the treatment part. So before that, let us discuss on the clinical features of multiple sclerosis. What are the clinical features? The first clinical feature is they're going to affect the long tracts of the spinal cord. Long spinal cord tracts. So these are called long tract signs. In the spinal cord, there are few tracts that are heavily myelinated, and that is the target for MS. What are the tracts that are heavily myelinated? What are the tracts that are heavily myelinated? So that becomes a target for multiple sclerosis. Of course, the first tract is posterior column. Of course, one of the most heavily myelinated is posterior column. Then the second tract is corticospinal tract, of course, and the third tract that is again heavily myelinated is spinocerebellar tract. These are the 3 tracts that are going to be the classic target for MS. But usually, since it's a typical demyelinating disease, they spare the spinothalamic tract. And they can produce a kind of disease sensor loss. I'm not telling no, but generally they tend to spare the spinothalamic tract. And that is also one reason we call that the demyelination is often incomplete, which means the spinal cord involvement often incomplete. It only causes, if it causes acute transverse myelitis, they'll cause only partial transverse myelitis. They'll not cause a complete transverse myelitis because certain tracts will be definitely spared. So if you have a posterior column involvement, of course, you will have loss of posterior column sensations. There's no doubt about that. Apart from that, you will have some characteristic signs because of loss of posterior column. One is the classic Romberg sign. Romberg sign is very classical. Remember, even though we call it acute transverse myelitis, remember, they will produce only asymmetric involvement. That is why I'm telling you asymmetric, asymmetric, asymmetric. I mean, every word I tell you is very important. Why I told asymmetric here? Because many students will ask the question, how can you see Rombergs if it is symmetric? Both the posterior column involved. Then how can you get Rombergs that are swaying towards one particular side? That's why I'm telling it's asymmetric. That's why you're going to get Rombergs here very commonly in multiple sclerosis if it's involving the posterior column. Then you will get something called a Lermit sign. So many students ask, Lermit sign is a sign of cervical spondylosis. No, Lermit sign can be seen in any disorder that affects the posterior column. Lermit sign is an electric shock-like sensation that will be seen in that will be felt by the patient whenever there is a sudden flexion of the spine. That is what we refer to as Lermit sign, or otherwise refer to as something called a Barber chair sign. That's Lermit sign. So which means anything that affects posterior column can produce Lermit sign. For example, cervical spondylosis can produce, multiple sclerosis can produce, tabes dorsalis can produce, subacute combined degenerative spinal cord can produce, Friedreich ataxia can produce. There is another entity called radiation myelopathy. I mean, remember, radiation also affects the myelinated tracts only. Radiation loves myelin. Usually radiation of the spinal cord usually destroys the myelin most often. So all these disorders can cause Lermit sign. If they ask you differential diagnosis of Lermit sign, it's not only one condition that's going to produce Lermit sign. That is again due to the involvement of the posterior column. And most of the time, the posterior column involvement is the one that is directly related to the development of the Lermit sign. So apart from the Lermit sign, there will be one more sign that is called a pseudoarthrosis. Pseudoarthrosis. So what do you mean by pseudoarthrosis? So whenever you ask the patient to, like put the hands like this in the front and turn and keep like this, most of the time if I see, I know the position. Suppose if the patient doesn't know the position of the hand in air, slowly, because they don't know the position, they start moving their fingers. That is without their knowledge because they don't know where the position is there. So if they start moving their fingers like this and turning the hands like this because they don't know the position properly, so once they see, then it's fine. So they will maintain it a normal position. This is what we refer to as pseudoarthrosis, very classical of a posterior column involvement. And of course, they are going to have a sensory ataxia. This is another evidence of a posterior column involvement. So what do you mean by sensory ataxia? It's a type of ataxia where the patient will have a high stepping gait, but with a stamping authority. So whenever they tell a high stepping gait with a stamping authority or a stamping type of a gait, that usually indicates a posterior column involvement. Because again, why they stamp? Because they don't have the joint position. If you don't have the position of, if you don't know the proper position of the joints in air, you might try to forcibly press your foot on the floor, and that creates kind of a stamping authority. That's what we refer to as a stamping kind of a gait. So these are the characteristic features of posterior column involvement in multiple sclerosis. Then you can have loss of corticospinal tract function, like they can develop hemiparesis, they can develop paraparesis, but always remember it will be asymmetric. Even if they develop paraparesis, there can be quadriparesis also. Even if they develop quadriparesis, even that will be asymmetric in nature. They will not be equal on both the sides. And the spinocerebellar tract involvement, they are going to result in cerebellar signs. Of course, you know what are the cerebellar signs we have discussed already. But one classic triad that have been discussed as far as MS is concerned is what we refer to as Charcot's triad. Remember, this is not a Charcot's triad of ascending cholangitis, which tells you fluctuating jaundice, right upper quadrant pain, and your fever. Fever, right upper quadrant pain, and fluctuating jaundice is what we called as a ascending cholangitis triad. That's called a Charcot's triad. And if you have altered sensorium and other stuff, it's called as a Reynolds pentad. You would have studied in ascending cholangitis. But this Charcot's triad is completely different. So what is this Charcot's triad? This is I usually remember is a SIN triad. What do you mean by SIN? S, I, and N. S stands for staccato speech, and I stands for intentional tremors, and N stands for nystagmus. So staccato speech, intentional tremors, nystagmus, all these things are, these are the three characteristic features of Charcot's triad, which is described for multiple sclerosis. But remember, this can be seen in any other cerebellar involvement. Just because Jane Charcot discussed this triad for MS, it's traditionally important. That's why for exams it's important. Apart from that, this triad is not specific for MS. It can happen in any patient with the other cerebellar involvement also. Second, optic neuritis is very, very important. Optic neuritis. So remember, 20% of the patients tend to have optic neuritis. Yes, INO can be there. I'll come back to that. We have not discussed yet. We have discussed only the spinal cord problems. We have not discussed the brain problems yet. So 20% of the patients tend to have some form of optic neuritis. 1 in 5 patients, a very, very important feature of multiple sclerosis as well. And most often, if they ask you the most common first neurological presentation, you can answer optic neuritis. Most common first neurological presentation is basically optic neuritis only. That's the most common first neurological presentation, optic neuritis. And whenever you talk about an optic neuritis, it is very important to discuss about 4 important disorders. In fact, optic neuritis versus papilledema is the most important. But let me also tell you how to differentiate optic neuritis versus papilledema versus you have central retinal artery occlusion. Before that, AON is the acute ischemic optic neuropathy. Then you have a central retinal vein occlusion, CRVO. How you're going to differentiate all these things in a from a common medical perspective. First, age of the patient age will be usually optic neuritis will be in a young age, less than 50 years. Age can be anything in the setting of a papilledema. In AON, usually the age will be more than 50, but it will be less than 70 because it's usually due to central retinal artery occlusion. I mean, sorry, not less than 70, usually more than 50, but very common, it will be in extreme elderly. So more than 70. I don't know why it was less than 70. Okay, fine. So as far as CRVO is concerned, again, it happens after 50 years of age. So AON, CRVO, elderly, optic neuritis, younger, papilledema in any age, because papilledema is due to raised ICP. As far as the vision is concerned, so remember, the most important feature is the central vision loss. I think I've told you this point already. Most important is going to be the central vision loss. The central vision will be lost in the setting of a optic neuritis. So why central vision loss is important? Because the patient is going to be completely blind. So if you're not able to see what you wanted to see, for example, my central vision is the one that sees what I wanted to see, focus. So if I'm not able to see what I wanted to see, the patient will come immediately. So central vision loss, it will be very catastrophic. Patient will tell, I'm not able to see anything. My vision is gone. That's why the patient will come. And most often, this loss will be rapidly progressive, and it will be most often monocular, which means most often it will be asymmetric in nature. It can be bilateral, but very commonly it will be asymmetric. On one side, it will be more severe. Most often in papilledema, you will have a peripheral vision loss. Peripheral loss compared to the central vision loss. That's why called enlargement of the blind spot. And as far as the vision is concerned, they will have only late vision loss. Because it's peripheral loss, the central vision takes a lot of time to get damaged. So it will be a late vision loss. And you know how AON is going to present? AON is going to typically present like a painless, acute loss of vision, and it will be a field defect. Acute field defect. Most common field defect, already we know it is an altitudinal defect. We studied already. So most often it will take hours to days. It will not be very acute, it will take some hours to days. And CRVO, again, it's a painless, unilateral, variable vision loss. They don't have a fixed kind of a pattern. And color vision loss, there are 2 areas where color vision loss will be lost. One is your optic neuritis. Color vision is something that is very early, affected very early in optic neuritis. And color vision can also be affected very early in AON. Other 2 things, here color vision loss is variable in CRVO, we cannot comment on it, but papilledema, color vision loss will be usually very rare. You don't get color vision loss in the setting of a papilledema. And as far as the symptoms are concerned, optic neuritis will be typically associated with pain. And if somebody asks you, where will be the pain? Pain on extraocular movements. That's the most important point. But if you take ophthalmic textbooks, you'll be a little confused because in ophthalmic textbooks, they'll be giving this as a painless loss of vision. That's what optic neuritis is all about. But remember here, the pain I mean is on extraocular movements. It's typically given in any ophthalmic textbook also. Pain on extraocular movements. And at the same time, usually, like as far as papilledema is concerned, the only feature of the patient will be a chronic headache most often, or acute headache also, but headache will be the most important feature because it's due to raised ICP. And that is the reason for development of this particular type of headache. Plus or minus, they can have a focal neurological deficit like cranial nerve 6 palsy. That is because of the raised ICP again, possible. And AON is concerned, it's variable. Again, symptoms will be variable. But we have discussed two types of AON. One is arthritic type of AON. Second is non-arthritic type of AON. If it's an arthritic type of AON, typically you will have giant cell arthritis-like features. You know what are the giant cell arthritis-like features? So actually in the world, if they ask you what is the commonest type of AON, it is arthritic type of AON only. But in India, it's very rare because giant cell arthritis in India itself is very rare. What are the features of giant cell arthritis? Headache, scalp tenderness, and the patients may have jaw claudication and extremely elevated ESR and CRP. So these are some of the features of giant cell arthritis, and this will be there in arthritic type of AON. It's non-arthritic, nothing will be there. They will not have headache, they will not have scalp tenderness, they will not have jaw claudication. ESR, CRP will be normal. So because that is due to atherosclerosis. So I can remove this off. So there are two types of AON. One is arthritic type of AON and non-arthritic type of AON. And CRVO, variable again. You don't get any symptoms, but only risk factors, cardiovascular risk factors will be there because it's an atherosclerotic disease. Then what about the pupils? Pupils, which means I'm talking about where you will have RAPD. That is relative afferent pupillary defect. One of the classic areas where you develop RAPD is your optic neuritis. You will not have RAPD here in relative in papilledema. RAPD is again a classic feature of AON, but RAPD may be there or may not be there. Again, it's variable in setting of a CRVO. But first of all, what is RAPD in the first place? If anyone can tell what is RAPD, relative afferent pupillary defect, it will be great. Because if you're good in ophthalmology, you have to tell RAPD. RAPD, that is called a Marcus gun pupillary response. Everyone knows that. And there are some final year students over here who should be able to tell what you mean by RAPD. Yes, that's a swinging flashlight reflex only. Relative dilatation, pupil dilated after tired, conjugate lost. I don't know, but what ophthalmology tells you, I don't know. But what we see in clinical practice is very simple. So first, initially, let us assume there is an optic neuritis in this eye. So you have a pupil. So let us see the normal response first. Now you do a light here. You're keeping a light here. And of course, once you give a light, you're going to have a constriction of the pupil. So let us assume this is the normal response. So this is normally without light and with light. This is without light, this is the size, and this is with light. You have both direct as well as concentric light reflex. Even if you swing from side to side, this is going to be the response. Same response you will get. This is going to be the response. Whatever you do, doesn't matter. This is assumed if the optic nerve innervation is 100%. The optic nerve is normal, 100% innervation. This is what you're going to get. But in the setting of an optic neuritis, let us assume this eye is there. This is not, without light, this eye is receiving only probably maybe 70% of the innervation. This eye is receiving 100% innervation. Just to make you understand. So now what happens is, now when you are showing light on this particular eye, now if you see the response, what will happen is this eye will go for constriction and this eye will also go for constriction. But remember, it is not like normal. Why? Because you have only 70% innervation on that side. Now you swing the flashlight to this eye. Now swing the flashlight to this particular eye. If you're going to swing the flashlight to this particular eye, now this eye is having 100% innervation, so they will take the light in a much better way. So they're going to constrict more and they're going to achieve a normal constriction. Now they're going to get a normal constriction. So that's fine. You'll not be able to see that. But when you're going to swing the light from this side to this side again, now it's fully constricted. Now if you're going to swing the light from this side to this side, now what happens is this side is not getting 100% innervation. So it's going to get 70% innervation only. So which means the pupil will go back to the original 70% level. It will still be constricted. I'm not telling it will be losing its constriction. It will still be constricted only. But it appears as if the pupils are getting dilated from the previous value. It's very peculiar. Basically, it appears as if it's dilated from the previous value, but still it's coming back to the original level where 70% of the fiber level only it's coming. So this is a relative constriction. This is not a full constriction, by the way. So that's why this kind of response is what we refer to as a RAPD, that is relative afferent pupillary defect. So it appears as if it's dilating from the original level of constriction. That is because this eye is having only lesser innervation compared to the normal eye. So when you go to the other eye now, so this you can demonstrate again and again. When you go to the other eye, you'll be having a full constriction again. When you come back to this eye again, it'll appear as if it's relatively dilating. So cool, isn't it? So again, when you come to that, I mean, you can easily find out when coming to which eye, it appears as if it's getting dilated. So that eye is the defective eye, and that eye is the place where you're having a optic nerve abnormality. So this is what we refer to as a RAPD, relative afferent pupillary defect. And this kinds of dilation and severe apparent dilation. So this should not be called as a dilation. So this is basically an apparent dilation. Why apparent dilation? It's actually constricting still, but constricting only to the level of your optic nerve innervation. That's also, it's an apparent dilation, not a real dilatation. It appears as if it's a dilation that is happening. So this is what we typically call as something called a RAPD, relative afferent pupillary defect, very classic sign of an optic neuritis. Remember, to develop this relative afferent pupillary defect, one important prerequisite is lesion should be asymmetric. If it's bilateral, it should be asymmetric, or it should be unilateral in nature. If it's bilateral and symmetric, then RAPD cannot be appreciated by clinical examination. What is the gold standard investigational analysis for RAPD? One investigation, if you want to do, that is going to detect this RAPD in a technical way. So what is that investigation? RAPD is a clinical way of finding out optic nerve problem. What is a technical way to find out RAPD problem? Problem in the optic nerve. Oh my God. There is something called VEP, visually evoked potentials. Visual evoked potentials, VEP is the gold standard, basically. So RAPD is only clinical, you can predict, but to confirm optic nerve issue, you have to do something called a VEP, visual evoked potential. That's going to be the most important investigation. Whenever I think about optic neuritis, the next investigation I'll be doing is sending the patient for a VEP, visual evoked potential. And what will be the fundus examination? As far as the fundus examination is concerned, the disc swelling may be there. There will be blurring of the disc. Blurring of disc margin will be there. Why blurring of the disc margin is that? That is because of the edema of the disc. But remember, more importantly, the disc can be completely normal if it's a retrobulbar neuritis. In retrobulbar optic neuritis, the disc can be completely normal. There are famous sayings also, isn't it? Neither the patient nor the doctor sees nothing. Yes, that is... no, not only the patient. Then neither the doctor nor the patient. Both will see nothing. So that is retrobulbar neuritis. Patient sees everything and doctor sees everything. That is papilledema. Patient sees nothing, but doctor sees. That is a optic neuritis. Patient doesn't see, doctor sees. Optic neuritis. Patient also sees, doctor also sees findings. That is papilledema, because late vision loss. Patient, doctor, nobody sees anything. Both can see nothing. That is retrobulbar neuritis. So these are the analogies that are there. But anyways, nevertheless, in retrobulbar optic neuritis, you're going to have a normally appearing disc only. You're not going to have any issues at all. And remember, in optic neuritis, as I told you, it will be completely asymmetric. Fundus examination will be mostly on one side only. Other side may be completely normal or will be having relatively lesser findings. But papilledema, you know, it's due to bilateral, raised intracranial pressure, which means it will be bilateral and symmetric findings. Symmetric findings will be there, which means bilateral blurring of disc margins will be there. If you have a symmetric bilateral blurring of the disc margins, very commonly it goes towards papilledema. And more importantly, you will not have hemorrhage, you will not have any retinal pulsations. It will be bland. Only disc edema will be there and it will be bilaterally symmetrical. That is papilledema. Optic notice, we know it's going to be more asymmetric in nature. As far as fundus is concerned, it depends whether it's an arthritic type of AON or a non-arthritic type of AON. If it's arthritic type of AON, most often you will see something called a pale edema. That's all. If it's a non-arthritic type of AON, it will be more of a red edema. Which means in non-arthritic type, most of the time they will be associated with hemorrhages. Hemorrhages, especially these hemorrhages are basically flame-shaped hemorrhages. And they can have dot blot type of hemorrhages also. So this is the fundus finding in a AON, anti-ischemic optic neuropathy. And here also you'll have in what is that? In CRVO also you'll have a swollen disc basically. And more often they'll be having a retinal hemorrhage. Retinal hemorrhage. So that is why I told you in papilledema, you will not have any retinal hemorrhages. That goes against papilledema. You will not have anything. You will be just having a bland blurring of the disc margin that will be bilaterally symmetrical. Very, very important point. So then as far as the etiologies are concerned, most important etiology in exam is MS, or it can be a, yes. I mean, if you want to tell, usually I'm taking it logically, you will have a splashed tomato appearance, isn't it? I mean, usually these students tend to confuse this splashed tomato with pizza pie appearance. Where you get a pizza pie appearance of the fundus. I mean, if I start asking about all the findings of the fundus, then it will be tough. Pizza pie appearance, yes, it's CMV retinitis. Splashed tomato appearance. Cattle truck appearance is CRAO, we know that. So we not discuss about that fundus appearances and all, but whether you are able to find it or not is more important. MS, viral here. And here etiology is raised ICP. That's the most important etiology here. And we know arthritic means it is giant cell arthritis. If it's non-arthritic type, it is atherosclerosis. So there's no need to mention again here. CRVO usually is associated with vasculitis or thrombus formation. Thrombosis or vasculitis of the veins. Something will be the case. As far as investigation is concerned, the investigation I'm going to is MRI with gadolinium contrast. That is to rule out multiple sclerosis, and I'll be doing a visually good potentials also. Here, once again, I'll be doing a CT or an MRI to see some space occupying lesion, which can be still there in this setting. If CT MRI is normal, you know what you're going to do. Of course, whenever there's a papilledema, headache, CT MRI normal, next thing is to see the CSF opening pressure. Rule out benign intracranial hypertension. Remember, if normal, I'm not telling it always be normal. Sometimes they can show space occupying lesions. If it is normal, then next step is to do a CSF opening pressure to rule out benign intracranial hypertension. Then here, the most important investigation will be temporal artery biopsy, because very commonly it will be a giant cell arthritis. If it's not a giant cell arthritis, it is not needed. And I'll be doing a CBC, ESR, CRP, because all these things will be tremendously elevated in giant cell arthritis. It will be normal in setting of non-arthritic type of AON. And two things are very important here. One is fluorescent angiogram. You would have studied all the fluorescent angiography findings in ophthal. So that's waste of time now to discuss. Plus or minus, I'll be doing OCT. Now for every investigation, we are doing OCT. I mean, for every ophthal problem, especially retinal issues can be well diagnosed with optical coherence tomography. You would have studied, isn't it? Below which layer, if there is a defect, what is the problem? That's very important investigation as of now. Optical coherence tomography. Then as far as the treatment is concerned, here IV methylprednisolone, pulse dose methylprednisolone is going to treatment because it is multiple sclerosis most of the times. And even in optic neuritis without evidence of MS, we are going to give IV methylprednisolone only. And here treatment of underlying cause, because the raised ICP is the feature here. Treatment of underlying cause, like if it's a benign intracranial hypertension, treat with lumboperitoneal shunt or optic nerve fenestration. You know that. So here, if it's arthritic type of AON, then you are going to give steroids. That's the most important treatment. If it's non-arthritic, I mean steroids plus aspirin. If it's non-arthritic type, I'll be using only aspirin, nothing else. So then if it's a CRVO, then I can use the most important as far as we know is VEGF inhibitors. That's what we very commonly use, like bevacizumab. Bevacizumab is not commonly used right now. Right now we use ranibizumab. That's the common drug that we use. Intravitreal ranibizumab is very commonly used. But most importantly, you have to correct the risk factors like diabetes, hypertension, if there is any. Then you have to reduce the intraocular pressure by probably using some drugs like carbonic anhydrase inhibitors. Topical astazolamide or dorzolamide may be helpful. And you can use laser reduction. Like for example, you can use vitreal laser. Plus or minus we use VEGF inhibitors. We know what are the VEGF. One is bevacizumab, second is ranibizumab. But most commonly in the current ophthal practice, they use ranibizumab very, very commonly because bevacizumab was once upon a time banned by AIMS. That is the reason why they didn't use bevacizumab. Currently, everyone prefers using ranibizumab here. Very common drug that is used in ophthal practice. So these are the differences between these four common conditions: optic neuritis, papilledema, AON as a CRVO. As far as the AON, I mean optic neuritis is concerned, the central vision loss, early loss of color vision, pain on extraocular movements, pupil showing RAPD, and abnormalities in visually evoked potentials. Then blurring of the disc margins, and most of the findings will be asymmetric in nature, and the treatment is going to be IV methylprednisolone. These are the points that are take home as far as the optic neuritis is concerned. I think with this itself, you can write an essay on optic neuritis itself. This must be more than enough to be precise. And everyone is asking about break. I'll give you a break because I started late and I repeated also some 20 minutes of topic. So I cannot give you a break right now. It will take another 10 minutes, but it will be a short break. This time I'll not be going to give a long break. It will be only 15-20 minutes of break I'm going to give. Okay, fine. And third thing, after optic neuritis that we need to discuss is on INO. Already I discussed about INO, that is internuclear ophthalmoplegia. I mean, basically, like internuclear ophthalmoplegia, my question is, will produce diplopia or will not produce diplopia? Internuclear ophthalmoplegia will produce diplopia or will not produce diplopia? INO. It's an ophthalmoplegia, right? Will produce diplopia or will not produce diplopia? That's very important. Usually, internuclear ophthalmoplegia will not produce diplopia. Commonly, they will not get diplopia. So, how can you understand internuclear ophthalmoplegia? I mean, first of all, you know very well that you have this cortical influence. From the cortex, you have this cranial nerves number 3, 6, and 3, 4, 6, isn't it? In the subcortical regions, you have 3, 4, and 6. These things are basically united together by something called a medial longitudinal fasciculus, MLF. And you have cortical influence on all these things. I mean, just to understand as a overall entity. So cortex have influence on all these things. And MLF is connecting this 3, 4, 6. So to produce this coordinated kind of movement, that's the function of MLF. And of course, this 3, 4, and 6 is further going to produce cranial nerves to innervate the muscles. And you have a neuromuscular junction also. So to produce an eye movement. So this is the overall arrangement that we are having, if you want to tell in a very simplified way. So to be honest, if you have a muscle problem, myopathy can produce diplopia, but very rare. Or if you have a neuromuscular junction issue, like for example, you have a myasthenia gravis, can produce diplopia, can produce ophthalmoplegia. Or you can have a cranial nerve issue, cranial nerve disease, or cranial nerve disorder, or cranial nerve damage, which can produce ophthalmoplegia. Or you can have a nuclear problem like this. So I can write in a different this thing. So a nuclear problem can produce ophthalmoplegia. Or it could be an MLF problem that we have discussed already that produces something called a internuclear ophthalmoplegia. If the problem is above the MLF, that can produce ophthalmoplegia, or they can produce a type of ophthalmoplegia called as supranuclear palsy. Supranuclear palsy. Sorry. That is called a supranuclear palsy, isn't it? All these levels can produce some form of ophthalmoplegia. We know supranuclear palsy is going to produce most or more often a vertical case involvement. INO, you know what is going to produce. They're going to typically produce that kind of, what is that? Medial rectus involvement with normal accommodation. So in that, if you see, usually the supranuclear palsy and internuclear ophthalmoplegia will produce ophthalmoplegia, but they generally do not produce diplopia. The patient's primary symptom will not be diplopia here. That's very classic, and that's how clinically they present. Nuclear lesions is variable. They can produce or they may not produce diplopia. It's variable. But these three, cranial nerve disease, myasthenia gravis, and myopathy, usually they come with diplopia. And that will be the primary complaint of the patient, double vision. It all depends where the problem is. So in general, you can remember that nuclear, cranial nerve, myasthenia gravis, myopathy are going to present with diplopia commonly. Whereas the supranuclear palsy and internuclear ophthalmoplegia, generally they do not present with diplopia. For example, you think a progress supranuclear palsy. Our patients are going to complain of diplopia. An MS patient is going to come off diplopia because of internuclear ophthalmoplegia. Usually they will not have diplopia. And remember, INO, you know the characteristic features. The medial rectus on one particular side will not function properly, and they will not have diplopia, and they will have a normal accommodation. That's the characteristic feature. But remember, if you have a supranuclear involvement, accommodation or a INO, accommodation will be intact, will be spared, because it follows a separate pathway. If you have a nuclear, cranial nerve, myasthenia gravis, or myopathy, accommodation also will be defective. In the sense, like if medial rectus is affected in that whatever lesions I told you, accommodation will definitely be affected in setting of a nuclear, cranial nerve disease, myasthenia gravis, and myopathy. But accommodation will be usually spared in the setting of a supranuclear palsy and internuclear ophthalmoplegia. And whenever they tell accommodation is spared but medial rectus is not moving properly in exam, it always means a internuclear ophthalmoplegia due to MLF involvement. So that's a very important thing to know. So that's why I told you about INO. So you need to know that whether they produce diplopia or not. In INO, usually patients' complaint will not be diplopia. They don't come with diplopia basically. That is internuclear ophthalmoplegia. Apart from that, many constitutional symptoms and signs will be there in a patient with multiple sclerosis. One of the important constitutional symptoms is fatigue. And this is extremely important because this is the most common symptom in multiple sclerosis patients. Very, very, very important. Fatigue. Fatigue is a very important symptom of a multiple sclerosis. So if they ask you most common symptom, it's fatigue. That's all. It can worsen tremendously. And we have separate treatment of fatigue for MS. There is a separate chapter on, if you take a MS textbook, any book, how to treat fatigue itself is a separate chapter. But if you want to tell in one word, amantadine is the treatment for fatigue. That's the usual treatment that we give, which we'll be discussing separately. Apart from that, you have so many problems. Nystagmus, oscillopsia, palinopsia, so many problems can happen in MS, but nevertheless, so these are the four important things that you need to know. So one is the spinal cord involvement, second is the optic neuritis, third is going to be the INO, fourth is going to be the constitutional symptoms. This is extremely classic. And they can come with ptosis also because they can affect the human. So they can come with ptosis. MS is a very common disease that produces ptosis. So one of the common features. I mean, why I'm telling you this? Because even myasthenia gravis can come with ptosis. One of the common symptoms of MG is also ptosis. So you see diplopia. The diplopia is there not. MS does not usually have diplopia unless and until they have significant optic nerve. I mean, it's more of a vision loss, not a diplopia. Diplopia usually goes against MS, according to me. If you give a diplopia in exam, I don't really diagnose MS. I want to go for other disorders. Be very clear about that. It produces blurring of vision, blindness, loss of vision, central vision loss, optic neuritis, but really does not produce blindness. And there are 2-3 things that you need to know. Already I told you about Lermit sign, but one more thing is there. One is Pulfrich effect is there. Do you know what you mean by Pulfrich effect in MS? What is Pulfrich effect? Anyone? Aha, no. Rigid old bath. That is Utah phenomenon. Pulfrich effect is basically a three-dimensional effect that is generated. Pulfrich effect is basically a three-dimensional effect. For example, not a pendulum-like effect. For example, it can be easily generated basically. So how can you generate this? You see a train moving. There are a lot of, it's a depth effect. A lot of videos available, so you can see the train moving. But all you need to do is put a glass. One glass is there, and you remove. If you have any broken glass in your home, especially coolers, you remove the one side this thing eyepiece, and only with one eyepiece you watch a moving object, a train, something sort of a thing. So you will be able to see that train is coming like this and going. It will be like a 3D kind of an effect. So that's a depth effect. So that's a 3D like effect you will get. So that's Pulfrich effect. What is Pulfrich effect? It's like a three-dimensional kind of an effect that you get in patients with optic neuritis. That's a Pulfrich effect, very common in MS patients. Why? Because why you get with a cooling glass? First of all, you understand that. Why you get that kind of effect in a cooler with only one side? That's because in the right side, because you're having a cooler eyepiece, it will actually cause a reduced intensity of light. So the optic nerve that will be stimulated from the right eye through the right eye will be very less. In the left eye, you are not wearing any eyepiece, you have removed that. So you will have a full light intensity that is falling on the optic nerve. So there will be a differential intensity of stimulus on both the optic nerves. If there is kind of a differential impulse like this in both the optic nerves, then in that setting, you're going to result in this kind of a 3D-like effect or a depth effect. So where the thing tend to go, especially for laterally moving objects. So this is what we refer to as a Pulfrich effect. It's not a specific, it can be seen in any condition that produces optic neuritis, not only MS. At the same time, it can be seen in other conditions like cataract also. Or you can artificially simulate like this kind of coolers where you can remove one side and you can remove and put on only one eyepiece. So it's not very specific for MS. That's the final take-home point. But it's typically described for multiple sclerosis. It's an effect due to optic neuritis because of differential illumination. And this Pulfrich effect also tells that the disease must be asymmetric, isn't it? If it's symmetric, you cannot get Pulfrich effect. Only if it's asymmetric, differential illumination of both the eyes and differential stimulation of optic nerve in both the eyes, you will get Pulfrich effect. That's in MS. Then second is here something called Utah phenomenon. Everyone will be knowing about Utah phenomenon. Utah phenomenon is basically heat sensitivity, and many MS patients exhibit heat sensitivity. They cannot tolerate heat. So Utah phenomenon means they will feel like the symptoms are increasing when they are exposed to heat, like hot bath when they go for traveling, when they go into tropical climates like India. Of course, this is going to worsen. So because they get increased symptoms and they feel like the symptoms are worsening, this is also referred to as something called a pseudo-exacerbation. And this is a very important thing because MS patients are known to get relapses and remission. That's why MS is most commonly going to present. So if you really want to know, like these patients are really suffering pseudo-exacerbation or not, one thing is this Utah phenomenon will be very acute, sudden onset, which means the moment they get exposed to heat, their symptoms will worsen. But the patient will be very scared because they feel that it's a remission of a MS attack. So because the MS comes as relapse and remission, the patient will feel like, oh my God, I got a relapse of MS and I'm getting a worsening of symptom. But you can clearly differentiate, it will be very acute. The moment they get exposed to heat, their symptoms will worsen. So acute will be more of a Utah phenomenon, pseudo-exacerbation. Whereas we know that MS, I told you multiple times from the beginning, I'm telling you. That's why each and every word I tell you, you should listen carefully. So previously, I've told you in the beginning itself, in acute transverse myelitis itself, MS will be more subacute in nature. It will not be acute in nature, which you have clearly described. And as far as MS is concerned, it will be more subacute and more asymmetric in nature. That's why I'm reiterating these points again and again and again. So in MS patient, to differentiate between a pseudo-exacerbation versus exacerbation, true exacerbation, one point is to see the acuity and the temporal association with the heat exposure. And third thing is, even if you are very unsure, if the patient is very scared, do an MRI. In MRI, you will not see any new lesions. That is typical Utah phenomenon. That's sometimes dangerous also because patient will be very scared because they will believe that they got a new attack of multiple sclerosis. Fine. So these are two effects that you need to know: Uthoff phenomenon and Pulfrich effect. Then you have some types of multiple sclerosis. What are the types of multiple sclerosis? I mean, which means the classification of MS or the types of presentation of multiple sclerosis. The most common type of presentation is called as RRMS. That's called a relapsing remitting type of multiple sclerosis. So what do you mean by relapsing remitting pattern? So the patient will be, let us assume this is the baseline of the patient. We are talking about the baseline neurological function of the patient. Suddenly they will get an acute attack. This is an acute attack of MS where acute in the sense like we are talking about a subacute deterioration. MS will never produce that kind of a sudden rapid deterioration. It's more of a subacute deterioration, but still we're talking about an acute attack in a relative term. So don't get confused. Suddenly they get an attack of MS. Their neurological status worsen. They'll get disabled. And over a period of time, they'll maintain the disability status for some time. And whether you treat or not doesn't matter. If you have an RRMS, automatically the disability status will improve and they will reach almost near normal function. So this is the most common type. 85% of the patients with MS will be having this kind of presentation only. So irrespective of the treatment, they are going to improve. But one small problem is they may not reach the original neurological function. They might have a little bit of low neurological function. If you see, the baseline that they're achieving here is lesser compared to the previous. So there is some disability that is still residual in this patient that is not recovered, but still nevertheless the patient will improve. And again, after some time, they will get another attack, which might be more worse or can be less worse, doesn't matter. But they will be staying in that for some time and they will go back. Even without treatment, they will improve. And once again, they will not reach the full baseline. They will have some residual disability. Now the new baseline you can see is like this. So this is a disability. So which means that every attack, the patient's disability is basically increasing. It's accumulating over a period of time. This is classical RRMS, but even with treatment or without treatment, somehow they are going to improve without a doubt. But after some point of time, what happens? There will be a scenario where the patient will not get this kind of relapsing remitting pattern, where they'll have a steadily declining neurological function. Very slowly, even without getting any sudden deterioration like that, they'll be slowly deteriorating over a long period of time. So this kind of MS is what we refer to as a secondary progressive type of multiple sclerosis. So, but remember, this is not very common. So usually this RRMS pattern is very common, but you can have something called a secondary progressive MS where there can be a slow deterioration over a period of time after getting initial relapsing remitting type of pattern. Or second pattern, you have something called a primary progressive MS, that's called a PPMS. So what will happen is they will get a attack of MS and after that there will be no remission at all and there will be a slow deterioration over a long period of time. So here there is no remission, relapse, nothing like that, no business. So it's like a primary progressive MS, primary progressive multiple sclerosis, no relapsing remitting. After the first attack itself, they will be having a steady deterioration only. There will be no improvement, like kind of a monophasic disease. It's not possible. Then you have some variants of MS. Like for example, you have a sudden fulminant attack, which will result in death. Initially, after the first attack itself, this is what we refer to as something called a Marburg variant. Marburg variant. Basically, it's a very sudden and fulminant attack. It will result usually in death of the individual, and we generally call it as a Marburg variant. Then apart from that, we have many other types of MS, of which is not important for you, but still just for namesake, I will tell you that's called a tumefactive MS. Tumefactive type of a multiple sclerosis. Usually this kind of MS tends to produce, it's MS only, but they produce some kind of a cystic lesion. Then we have something called a Schilder disease, which is extremely common in children of age 5 to 15 years. It's a childhood onset, which is not really that much important for you, but still just for namesake, I'm telling you. And one of the important features of Schilder's disease is their ability to produce pseudo-tumor-like lesions. Because in children, tumors are extremely common. They tend to produce pseudo-tumor-like lesions, typically more than 2 centimeter symmetric plaque-like lesions. Symmetric plaques. So very big plaques they will produce. That's like resembling a tumor. That's why it's called a pseudotumor-like lesion, and which is what we are going to call it as a Schilder's disease. And the sixth variant is called Ballous concentric sclerosis. Ballous concentric sclerosis. Okay. So two questions are important in this variance. One is one PGI question they asked, MS that produces cystic lesions in the brain, tumefactive MS, point number 1. So that's a PGI question 2017. They asked already. Second, MS type that produces pseudotumors in the brain, AIMS 2015 question, Schilder disease. 2 questions, that's all. Ballous concentric sclerosis, they have not asked, that's why I'm not discussing. Out of these 2 questions, if you remove these 2 questions out of the MCQ book, all the questions will be based on RRMS only. That is relapsing remitting type of multiple sclerosis. That will be the question. Only 2 questions they have asked. One is tumefactive and one is Schilder's disease. Apart from that, every single question in your exam will be based on relapsing remitting type of multiple sclerosis only. Clear? Suppose how will you evaluate this relapsing remitting type of, any type of MS for that matters. If they ask you the investigation that you can do in MS, the first investigation that you're going to do is, of course, MRI with a gadolinium contrast. So this is, if they ask you the investigation of choice, if they ask you radiological investigation of choice, if they ask you the gold standard, doesn't matter. So this MRI with gadolinium contrast is going to be the most important investigation, and every radiology faculty would have showed you how this plaque lesions will look like. So this is a white matter plaques that you're going to see. White matter plaques that you're going to see. And these are areas that have been demyelinated. These areas are basically demyelinated areas. That's what you're seeing as a white matter plaques. And there are some MS specific lesions are there. So what are the MS specific areas? If you see lesions in those areas, it's very specific for MS. These are called as MS specific areas. If you see plaques in these areas, they're very specific. One is the periventricular area, periventricular matter, so periventricular area. And second is corpus callosum. And third is the spinal cord. So these are very, very important MS specific areas. And this periventricular areas images only will get, yes, typically. So if you have a corpus callosum here, and you have a ventricle here. So ventricles, we can put like water here, ventricles here. And above this, you will be seeing this plaque distribution like this. There will be thick plaque distributions like this. And the cortex will be here. This is the cortex. So this is what you see in the sagittal section I'm drawing. Sagittal section. So if you see something like this, this is what we call it as Dawson fingers. Dawson fingers. So everyone would have showed you. So why I don't want to show the radiological image here is because this is something so extremely common and naive to show. I don't think this is really important to show. These are called as Dawson fingers. You can Google it and see every Google first image, you will see what is Dawson finger. It's very simple. But these are the MS specific areas. If you see plaques in these areas, that's very specific for multiple sclerosis. And why we use gadolinium contrast? If you MRI can show you why you want to really use gadolinium contrast. The idea why we want to use gadolinium contrast here is because it can tell you whether the lesion is old lesion or new lesion. So remember, typically old lesions will not take up the contrast. So they'll be non-enhancing only. Old lesions. And new lesions will take up the contrast, which means they will look as if they are enhancing. So they are enhancing. So these are basically MRI is gold standard because with gadolinium contrast, because you can differentiate old and new lesions. And similarly, T1, T2, yeah, T1 weighted lesions. If you see, these old lesions appear like a hole in the brain. These are called as T1 black holes. So old lesions typically, new lesions will not look like black holes. New lesions will look a little hyper intense. But old lesions in T1 weighted imaging, they look as if there is a hole in the brain, a black hole in the brain. So these are called as T1 black holes. And this is how old lesion will look like in T1 weighted MRI. But nevertheless, the most important thing to understand here is old lesions versus new lesions can be easily differentiable with the help of MRI with gadolinium contrast. So fine. So you understood this MRI with gadolinium contrast, why it is. Next question is why you need to differentiate between old and new lesions. That's the question here. So why you need to understand, because you have something called a McDonald's criteria. So currently we use revised McDonald's criteria. because MRI has improved a lot. So we use revised McDonald's criteria. It's a big criteria, but the crux is what I'm going to tell. McDonald's criteria is considered to be the gold standard for diagnosis of multiple sclerosis. So how you can diagnose multiple sclerosis McDonald's criteria? You are going to use something called a dissociation in space and time. So MS is one disease. There are some other diseases which can show dissociation in space and time. But if you correlate everything properly and clinically you understand in a proper way, the only disease that in exam that produces dissociation in space and time is MS. Especially the RRMS part, dissociation in space and time, is multiple sclerosis only. This is the exact basis of this entire McDonald's criteria. So let me tell you the dissociation between in space and time and what is the importance of that. So first thing, let me tell case number one where you get optic neuritis, first attack of optic neuritis. Then after this, you maybe after 4 months, the patient got another attack of optic neuritis. This is the second attack after 4 months. Second patient got optic neuritis, first attack. And after 4 months, patient got maybe paraparesis. This is number 2. Number 3, patient got optic neuritis and paraparesis at the same time, simultaneously. Among these 3, 1, 2, and 3, which is MS? Which is MS according to you? I mean, I'm not telling which is MS, which is probably MS, because clinically you can tell only probable. Everyone should be able to tell, isn't it? Which is probably MS. Yes, of course. I mean, by the way I told all these things, it must be quite easy to tell. So one is basically MS, because this is the one that shows the dissociation in space and time. So what do you mean dissociation in space? You see 2 different lesions in 2 different areas. One is an optic nerve and second is in the spinal cord. So definitely that's completely different. So 2 different areas. So dissociation space is there. And both are happening at a distance of time gap of 4 months. So which means there is the dissociation time also. So this is most probably MS, but I have to confirm with other investigation and clinical examination. So this is very likely, probably as a whole, it looks like a probably MS. But here, even though there is dissociation in time, I don't have any dissociation in space because both are optic neuritis, same location. So it may or may not be MS. So I cannot be sure. Similarly, if optic neuritis and paraparesis happen at the same time, so which means here I'll probably think about an NMO here. So if this is the case, I'll be thinking about an NMO where neuromyelitis optica, both are coming at the same time. But I don't really think about an MS because there is dissociation in space here, but there is no dissociation in time. Both are happening almost simultaneously. Clear? So I don't really think there is dissociation in time here. So in this particular examples, the number 2 is going to be the most probable reason for suspecting a multiple sclerosis. But more than that, your radiology gives a very vital clue. So because radiology can easily tell the dissociation in space, it can tell the lesions are separated apart by different areas. And on top of that, with enhancement, gadolinium enhancement, it can tell there are some reasons which some lesions which are enhancing, means this must be new lesions and these must be old lesions. And it can clearly tell you have dissemination in space as well as dissemination in time as well by differentiating between new and old lesions. That's why MRI with gadolinium contrast is considered to be the gold standard. You have so much of confusions here, but that is not the case right now. So what you have to understand is MRI with gadolinium contrast is the gold standard because it can easily prove the dissociation in space and time and can easily tell plaques in the MS specific areas at the same time. You can easily apply the McDonald's criteria to MRI. So that's why MS diagnosis is totally based on clinical examination and MRI findings only. And at the same time, you can do CSF. There is something called a CSF. As I told you, CSF, the most important finding is you look for oligoclonal bands, which is seen in more than 90%. Is oligoclonal band sensitive for multiple sclerosis? Answer is definitely no. These are non-specific for MS, but they're highly sensitive, which means more than 90% of cases will have OCBs, but it is quite non-specific. OCBs can be seen in blood also. For example, OCBs I can see in blood as well as CSF, But if I see in blood, not in CSF, definitely it is not suggestive of neurological disorder. If it's seen in blood and CSF, probably neurological disorder. But if it's not seen in blood, seen only in CSF, it's very, very specific for a neurological disorder. Which means if I see oligonucleotide bands in the CSF but not in the blood, it's specific for a neurological disorder. I'm not telling it's specific for MS. It's specific for neurological disorder. But overall, it cannot tell you what is the neurological disorder. Which means OCBs can be found in MS, OCB can be found in SLE-induced vasculitis and neurological damage, OCBs can be found in antiphospholipid antibody syndrome, APLA syndrome, OCBs can be seen in Lyme's disease, OCBs can be seen in neurosyphilis, OCBs can be seen in Sjogren syndrome, OCBs can be seen in Behçet's disease, OCBs can also be seen in neurosarcoidosis, which means OCBs can be seen in multiple other conditions, which means presence of OCBs only tell that the patient is having neurological problem, but presence of OCBs cannot confirm that the patient is having a multiple sclerosis. But even though absence of OCBs is little specific, little important, because absence of OCBs tells you that the patient might not have a multiple sclerosis. You are thinking you are dealing with some other disease. Like for example, neuromyelitis optica generally does not have OCBs. ADEM, acute disseminated encephalomyelitis, which I talked about, may or may not have OCB. So why this kind of enhancing lesions important? One more thing I forgot to tell. I told you this new lesions will enhance. That's very important. Remember, ADEM, you will see no enhancement. None of the lesions in ADEM will enhance, even if it's acute lesions. That's one of the important points. ADEM lesions will never enhance. Acute disseminated encephalomyelitis, clear. Okay, so then what else? As far as the MS is concerned, then CSF, one more thing what you can see. I told you it's IgG index. What are the IgG index? That Ig levels will be elevated. Ig index can be calculated by seeing the ratios of CSF IgG to the serum IgG. So for example, how will you say Ig index is you take CSF IgG divided by CSF albumin, and this should be whole divided by serum IgG by serum albumin. So this is what we refer to as Ig index, and this will be elevated in more than 60% of the cases with multiple sclerosis. And remember, Ig index is very important because this is usually normal in the setting of a neuromyelitis optica. That's a very important point as well. Normal in the setting of neuromyelitis optica. So CSF, not very important, but in exam, this OCBs and Ig index, definitely they will ask. And OCBs are not specific for MS, but it will tell you there is some sort of a neurological problem. That's what oligoclonal bands are all about. Then finally, we'll finish off this with the treatment of MS. Treatment of multiple sclerosis. As far as treatment is concerned, now only we are going to start with the pathophysiology. So myelin, we know it's going to be on the outside. Let us take an axon, and this is the myelin. Myelin has a very, very important protein. Let us assume these proteins I'm drawing are myelin basic protein, MBP, and these are thought to be the major antigens in MS. Myelin basic protein, MBP. And we don't know how these are becoming antigens. We have no idea, but these are acting as antigens in most of the cases. So this MBP is the one that is, recognized as antigens by the antigen presenting cells, and they are presented to the T helper cells. Like for example, let us assume this is a naive T helper cell. This is a CD4 naive T helper cell. This is an antigen presenting cell. So they're presenting through MHC class 2 to CD4 T helper cell, where it is recognized as an antigen, and where they are developing into T helper 1 group of cells. These T helper 1 group of cells, basically they're going to produce cytokines. So these cytokines are going to stimulate the local lymph node, and this local lymph node, once it's stimulated by the cytokines by the T helper 1 cells, they're going to release more and more T cells and more inflammatory cells. And these more and more T cells and more inflammatory cells will have to enter the blood-brain barrier now. We know that, isn't it? Now they have to enter the blood-brain barrier. Once they've entered the blood-brain barrier, they can cause more and more damage. So this is a cycle that's going to continue in a very easy way. If you want to tell, this is how the pathophysiology is going to be. So it's basically a type 4 hypersensitivity reaction where T helper 1 cells are going to be the most important. And at the same time, there is one more thing that is proven in multiple sclerosis. The T helper 1 response is basically overwhelming compared to the T helper 2 response and the T regulatory response. So T regulatory response, we know basically they're going to inhibit the immune system, and T helper 2 response is also like a kind of a suppressor of the T helper 1 response. So this is also one theory that tells, due to unknown reasons, that T helper 1 response within the brain is too much, and that is the reason why you get demyelination and multiple sclerosis. But nevertheless, that is not that important, but we need to know that drugs which are acting at different places. What are the drugs that can act? For example, there is one drug that can alter the structure of the myelin basic protein. And which means once the structure of the myelin basic protein is altered, its recognition by the antigen presenting cells will be completely stopped. And that drug is what we refer to as a glatiramer acetate. Glatiramer acetate, very, very important drug. So that's going to prevent the recognition of myelin basic protein as an antigen. That's a 3 amino acid drug that's called glatiramer acetate. It's a very, very important drug. So, I mean, it's 4 amino acid. So why the name glatiramer came? Because G stands for glutamate, L stands for lysine, A stands for alanine, and T stands for tyrosine. So these are the 4 amino acid sequence. And of course, because this is an amino acid based drug, peptide based drug, it has to be given subcutaneously. It's an injectable drug, but it's a very safe drug and very good drug. We'll be seeing about that in 2 minutes. So then these T helper cells, after releasing cytokines, they're going to cause the lymph node movement, the T cell movement out of the lymph nodes. So for this movement of the T cells out of the lymph nodes, that's called a T cell egress from the lymph nodes. For egress, you need something called a sphingosine 1-phosphate dilated pathway. So there is one molecule that is sphingosine 1-phosphate. So this is the molecule that is important for aggression of the T cells out of the lymph node and the immune system. So to block this sphingosine phosphate, you have a drug called fingolimod. So fingolimod basically blocks the T cell egress out of the lymph node, lymphatic system, which means they will sequester the inflammatory cells within the local lymph nodes. They will not allow the T cells to come out of the lymph nodes so that they can produce an immune response. And ultimately, the T cell entry into the blood-brain barrier, that's very important. So this can be stopped by a variety of drugs. And one of the most important drug in that situation is natalizumab. Natalizumab is a very, very important drug that can block the movement of the T cells into the brain by crossing the blood-brain barrier. Because to cross the blood-brain barrier, they need one important integrin that is called a alpha-4 beta-1 integrin, otherwise referred to as a VLA4, that is called a very late antigen number 4. So natalizumab is the monoclonal antibody against this alpha-4 beta-1 integrin, which is actually needed for T cell crossing of the blood-brain barrier. If that is blocked, then you cannot make the T cells move into the blood-brain barrier, so that you will result in reduced amount of inflammation. At the same time, you have another drug called interferon beta, which can act at multiple places. It doesn't only act on the one particular area. For example, it can down-regulate the T helper 1 response. Similarly, it can actually prevent, how the T cells are going to enter the blood-brain barrier, they're going to release something called matrix metalloproteinases that are going to lyse the matrix between the 2 endothelial cells so that they move into the blood-brain barrier. So this release of matrix metalloproteinases can be blocked by interferon beta. So interferon beta is going to act by multiple different mechanisms. So we need not really worry about that. So these are the drugs currently we have. So 4 important drugs. One is interferon beta, second is glatiramer acetate, third is the fingolimod we have discussed, and fourth one is the natalizumab. And apart from that, we have many other drugs, like oral drugs are there, which can be used, which we'll be discussing subsequently. But which drug to choose is a big issue as far as MS is concerned. But what drug to choose depends on the patient and depends on the physician only. There are 3 ways of approach. So one is going to be the convenience approach. Second is going to be the safety approach. Third one is going to be the efficacy approach. So in convenience approach, I want to use drugs that are given orally, which means I want some orally used drugs, which means patient needs convenience here. In safety approach, patient's primary priority is safety. For example, I need to use drugs with as little side effects as possible. At the same time, it should be pregnancy safe. There are some drugs that are pregnancy safe. That's what I need safety. That's where I need safety. Third is efficacy approach. Here, my primary idea is to reduce the disability and to prevent the relapses. That's the most important, which means here the patient is seriously disabled or getting multiple relapses. So I need to use some drugs that are going to be extremely effective against preventing relapses and to reduce the disability. So I have 3 approaches here. And as far as the convenience approach is there, I need to use only oral drugs. There are 3 drugs that are oral that are used in MS. One drug is fingolimod. So there are multiple O's in it. So can remember it's an oral drug. But the most important side effect they're going to ask as far as the fingolimod is concerned is going to be the first dose bradycardia. That's very important. That's why most of the times fingolimod we don't use, because I've seen one patient die because of this first dose bradycardia. So it can be very potentially serious also. That is the reason most of the times we give fingolimod in the inpatient setting. We don't actually give this drug in the outpatient setting. It has to be given in the inpatient setting only. Second, we have other 2 drugs that's called a DMF, that is dimethyl fumarate. That's also a very commonly used drug. And third drug, we have something called a teriflunomide. This is also a drug used in convenience approach only. All these are oral drugs. As far as the safety approach is concerned, there are 2 drugs which are very, very safe. One is interferon beta and second one is the glatiramer acetate. Both are very safe drugs, can be used in pregnancy also, and has very less side effects. But the problem is they are not convenient because they have to be given by injections and they have less side effects. That's why you are using in safety approach. As far as the efficacy approach is concerned, here the patient will be seriously disabled, getting multiple relapses again and again. So I need the safety as the priority. Efficacy as the priority. There are 2 drugs that are extremely efficacious. One is natalizumab and second is mitoxantrone. Mitoxantrone is an anti-cancer drug that can be used in MS. This was once upon my JIPMER quiz question. So they asked which is the drug that can be used in both MS as well as cancer, hematological cancers. Mitoxantrone, even though this is not used for this purpose right now, mitoxantrone is more of a multiple sclerosis drug. Very, very efficacious drug. But the problem is they are limited by high side effects. Number 1, and it has to be given by subcutaneous route as well. All are injectable drugs. So mitoxantrone is extremely effective in reducing the disability state. See, both can do, but mitoxantrone reduces disability more than reducing relapses. But remember, both can do both. They are very efficacious. Natalizumab is more effective in reducing the relapses more than reducing the disability. So why you have to reduce the disability? Because I told you at every stage in RRMS, the patient will have some form of residual disability. So you have to improve the patient's functional status to a higher level. So to improve the disability status and to maintain the patient in a good functional state, you need these drugs. These are the 2 drugs that can work nicely to give a better neurological function in these patients. But one important side effect that they'll be asking about natalizumab is the PML, because one important side effect that's going to happen here is PML, that is progressive multifocal leukoencephalopathy, which is a very, very important side effect. So whenever in exam you see this PML, you have 2 things that can cause. One is the what is that? HIV in terminal stage, CD4 less than 50. If they give HIV with CD4 less than 50, you can think about PML. Or second is MS patient on natalizumab. These are the 2 areas where you really think about having a progressive multifocal leukoencephalopathy, which is caused typically by the JC virus, which is a polyomavirus group. In exam, polyomavirus means 2 viruses, JC, BK. JC will be in the brain. BK virus will cause nephropathy in post-transplant individuals. Fine. So JC virus. Side effect is PML, progressive multifocal leukoencephalopathy. Mitoxantrone can produce cytopenias because it's used in hematological cancers. They can produce bone marrow suppression, cytopenia. So they are not safe drugs. At the same time, they are not very good drugs also from the side effect perspective. And interferon beta, if they ask you side effects, the most important side effect is going to be flu-like reactions. Any interferon if you give, the patient will get flu-like symptoms. That's the most important side effect as far as interferon beta is concerned. And so 3 approaches. This is very important, which means there is no standard drug that you're going to prefer. It's all about what is the approach, what you need, what the patient needs, and what as a clinician you need. And you have 2 more new drugs that are approved. One is CD20. These are anti-CD20 drugs. These are also currently approved for MS. One is rituximab, found to be little effective. And second is ocrelizumab. Both are anti-CD20 drugs. They are found to be effective in MS, and you can remember that also. But more importantly, all these drugs, whatever you give, these are for maintenance therapy. Whatever drugs we have preferred till now are for maintenance therapy. They either reduce the relapses or they improve the disability. But there is one important entity that we forgot, that these patients are getting something called a acute attack, and they are disabled during the acute stage for a longer period of time. So you need to have a drug that actually improves the patient to the baseline very fast, which means these drugs will not affect what baseline they are going to reach, but they at least improve the patient very fast, which means they can reduce the duration of relapse. They can reduce the duration of acute attack, which means they can shorten the duration of acute attack. And what are those drugs? So which means these are the drugs that are typically used in acute attack, like for example, steroids. And you can combine with IVIG. Very commonly used drugs. Remember, these drugs will not have any impact on disability. These drugs will not have any impact on the future relapses, but these drugs are important only during the acute attack, where they can reduce the duration of acute attack, or they can shorten the duration of acute attack. Clear? So they can shorten the duration of an acute attack. So that is why we are going to use steroids and IVIG. Otherwise, these drugs are not going to have any impact on the overall functional status of the patient, nor they are going to reduce the future risk of relapses in any way. Do you understand? Mechanism of glatiramer. Glatiramer is going to get incorporated into the MBP. And mechanism of all these drugs are not completely known. Glatiramer can get incorporated itself into the myelin basic protein, or it can be incorporated into the MHC2 of the antigen presenting cell, so that it will prevent the recognition of MBP as an antigen. That is the main mechanism of glatiramer acid. Even though it is not clearly known how glatiramer works, but it is like a modulating drug. It's like the immunomodulating drug. That's how it works. And anti-CD20 rituximab, we know that. And we have another drug that is ocrelizumab. Side effect natalizumab is PML, that is progressive multifocal leukoencephalopathy. EBV-VZ, we have so many EBV has been implicated in pathophysiology like vitamin D deficiency, but there is no concrete evidence. But in exam, if they ask you infectious relationship with multiple sclerosis, then you can answer Epstein-Barr virus. That's the most important. But there is no clear-cut pathophysiology with relation to Epstein-Barr virus. EBV, yes, agreed. MS being an important disease, I have described, I think, as much as possible with regards to MS. In the MS itself, we have studied so many other additional information also. Like we have studied about the second nerve, why it is not a true cranial nerve. Then we have studied about the posterior column signs. We have studied about the differential diagnosis of optic neuritis. Then we have studied about, like the diplopia causes, what can produce and what cannot produce, types of MS. Then we have studied about the different groups of drugs as well. So I think this must be enough for your multiple sclerosis. Okay, now you can maybe take a short break, maybe for 10 minutes. I'll come back at 8:35 itself. 8:35, we'll start again. Yes. Saurabh is asking for fatigue. There are many other problems with MS. There are 2-3 problems that will happen very commonly in MS. One is fatigue. For fatigue, use amantadine. Amantadine is an antiviral drug, but it's no longer used for that purpose because influenza, almost all the strains are now resistant for amantadine. So there are 2 uses for amantadine now. One is in Parkinson. It's a good Parkinson drug. And second is it can be used to treat fatigue in MS. These are only two uses in neurology as far as amantadine is concerned, but more importance is the use in Parkinson. It's a marginal efficacy drug, not a very good drug, but though in MS, it can be used to treat fatigue. We don't know the exact mechanism. Second, we have spasticity. How to treat because spasticity is a very, very important problem, because the lesions what you're getting in MS is basically UMN lesion. So how to treat spasticity? Spasticity will be treated with baclofen and these kind of antispastic drugs. The usual drug that we prefer is baclofen, and second drug we can prefer is tizanidine. You have studied this, isn't it? Tizanidine. So baclofen and tizanidine, these are the two drugs that we are going to use for treating spasticity. And there's another problem that we encounter in MS is oscillopsia. How to treat oscillopsia in MS? Oscillopsia in MS will be treated with gabapentin. Oscillopsia means when they see, the whole world will look like as if it's oscillating like a pendulum. So this is oscillopsia for them, which means it will not be stable. Vision will be like, because it's like you can run like an ataxia in the vision. So like there'll be like when you see a camera, and if you see me like this, I think now it will be a good demonstration of what is oscillopsia. So this is how they see, basically. That's oscillopsia. I think you would have known what is oscillopsia. That's how they see, and to treat that you can use gabapentin. Gabapentin is a good drug. To an extent it will work. And is any transverse maladies based difference between MS and NMO? NMO, yes, you can differentiate. NMO, the antibody, and there is not yet one particular antibody that is discovered for MS yet that can be commercially used. But NMO, you have an antibody, that is anti-NMO antibody. We'll be discussing about that. Second, LETM. LETM is never possible in MS, that 3 segment or more. Most of the time in NMO, there will be both spinal cord involvement and optic nerve involvement at the same time. Most importantly, there will be a complete involvement in the spinal cord with neuromyelitis optica, where there will be partial involvement in the case of multiple sclerosis. And at the same time, there will be necrotic lesions and severe edema will be there in NMO compared to that of MS. MS will not have that much edema and there will be no necrosis. But in necrosis and your severe edema is characteristic feature of neuromyelitis optica. Alemtuzumab, yes, I think it's not that useful, but it can be used. It's anti-CD52 you're asking about. Yes, can be used in MS. Alemtuzumab, anti-CD52, correct. Yes, alemtuzumab also can be used. But I mean, I've never used that drug, so I've not seen alemtuzumab in my hospital. I mean, maybe hematology centers will be more oriented to alemtuzumab. Clear? So, I mean, simply I'll finish off the NMO only before going for break. I'll give you 10 minutes break, don't worry. So as far as NMO is concerned, neuromyelitis optica, which is often referred to as something called a DeWick's disease. As far as DeWick's disease is concerned, we use something called a Winger-Chuk criteria. I mean, this is a very old one, but still this is enough for exams. But we have modern criteria for NMO spectrum disorders called as NMO-SD. But nevertheless, Winger-Chuk criteria tells that you have an LETM, number 1. So longitudinal extensive transverse maladies, we know the definition of LETM. Second, you should have optic neuritis. It can be either unilateral or bilateral. And third thing, the patient will have antibody positivity. Antibody in the sense, like there will be anti-NMO IgG positivity. Anti-NMO IgG positivity. Remember, many students think that anti-NMO IgG should be done in the CSF, but remember, blood has higher sensitivity, which means I generally tend to do anti-NMO IgG in the blood only, not in the CSF. But many even neurologists do in the CSF, but it's very clear in the literature that blood is doing in the blood has more sensitivity compared to that of the CSF. And additional optional criteria is there, that brain MRI criteria should not meet MS criteria, which means I can write brain MRI will not meet the MS criteria, should not meet the criteria for MS. That is the additional criteria. But these are going to be the most important. Sorry, it came back again. 1 second. These are the most important. So LETM, optic neuritis, antibody positivity, plus the brain MRI criteria will not meet the MS criteria. Remember, as far as DVX disease is concerned, the most important, the problem will be usually occurred in the spinal cord more. In MS, the problem will be more in the brain than the spinal cord. As a whole, if you see the diseases from a bird's eye point of view, spinal cord is the primary corner of lesion. Think about NMO. Brain as a primary area of lesion, spinal cord additionally, you see, then it must be a usual MS. And typically MS specific areas, like when you see the MRI, it will be very clear. Repeatedly, if you keep on seeing the MRI, it will be very clear that MS has some particular pattern and you know very well what you need to do. And at the same time, if they ask you what is the treatment that you're going to use for NMO, neuromultis optica, you're going to use pulse methylprednisolone. Number one, that's what you're going to use, plus or minus IVIG. This is the usual treatment, which means steroids and IVIG again. So that's the most important point that you need to know for exams. And if the patient is getting recurrent, usually NMO is a monophasic disease, but if you get recurrent attacks, then you can use maintenance therapy with azathioprine, mycophenolate mofetil, or even rituximab, because these are immunosuppressant drugs. Clear? So this is what you do as a NMO disease. And what is the other name? Everyone will be knowing, isn't it? What is the other name for this NMO IgG antibody? These are called as anti-aquaporin 4 antibodies. These are also questions in exam. Anti-aquaporin 4 antibodies, anti-AQP4, anti-aquaporin 4 antibodies. Same, both are same only. They're not different. Other name for anti-NMO IgG antibody, that is anti-aquaporin 4 antibody. Can anyone tell there is another antibody that can produce NMO-like picture? NMO is very difficult to understand, even though this much is enough for exams. But there is a whole spectrum of disorders called NMO spectrum disorders. NMO-SD is there. One antibody is there. I'm not talking about NMO IgG. Leave that. There is one antibody that is seen in connective tissue disorders that can give rise to NMO-like picture called as NMO spectrum disorder antibody. What is that antibody? Which can produce NMO-SD-like picture, NMO spectrum disorder. What is that antibody? Anyone? At least you can guess, no? Yes, only one has told it correctly. Sai has told it correctly. That is anti-Rho antibody, which is seen in CTDs, connective tissue disorders. Anti-Rho antibody has a very important association. That could be an exam question where you see NMO spectrum disease-like picture, which means you will see a disorder that is similar to that of NMO. That's called an NMO spectrum disease that you will be seeing in this kind of connective tissue disorders. Anti-Rho antibody, that is anti-SSA, otherwise called as anti-SSA. I think you can go for a break for some time, maybe 10 minutes. I'll take for another 1 hour after coming. So you can go for a break now. Okay. I think time is 8:32 now. I'll start by 8:45.